हाँ सही है।
Yeah, it's online. If you want, we can be there. Okay, and we can do like मैं first का summarize करूँ, first के बारे में बोलूँ, आप second का जैसे भी do it like that. Yeah, is it okay with you? Okay, okay. So we do that, right? Then first. No. That I have spoken to Dr. Vener and they proposed a slide which we have to like. So there will be slide of projection for all the speakers.
Good morning, Dr. Nishant.
No. The organizers they have made the arrangement. That I verified at 6 o'clock in the morning. Like Dr. Aditya showed, there will be a slide and we have to just read it out. We know what it will be. Similarly for Dr. Alok also. That I'm not sure, but this is maybe they'll be providing us the info on this. Okay.
Can you guys see my screen?
On your way to Mansi. Okay, take it.
Can you see my screen? Hello.
सर आप यू आर मोस्ट वेलकम सर, आप आ जाइए, मोस्ट वेलकम आप आ जाओ। बिल्कुल सर, सब कुछ है सर, आप आ जाओ। आपको कोई बोलिए, आपको बस आ जाना है। ऑन करो। नहीं, दे विल बी डूइंग ऑनलाइन, एवरीथिंग ऑनलाइन। Good morning, Dr. Nishant. Rather, good evening.
Yeah,
it must be.
It's late here.
Yeah, it must be 9 o'clock there in US.
No, I'm in Chicago, so it's 10:15.
Okay. So we welcome you the Delhi AOICON, and we will start exactly at 9 a.m.
Okay. Can you see my screen?
Yeah, I can see your screen.
And if I advance, whoops. And now you see it?
Yeah, it's moving.
Okay, great.
Yeah.
And you can hear me okay?
It's perfectly fine. It's absolutely fine.
Perfect, thanks.
So, Colonel Singh is also there. Dr. Vipin Arora and Dr. Colonel S.K. Singh will be chairing this session.
Okay.
Yeah.
Morning, Dr. Singh. I'm Nishant. Nice to meet you.
Good morning, Colonel Singh. How are you, sir?
Good morning, sir. So nice to be back, at least on the virtual platform. Good morning, Dr. Nishant.
Good morning, Dr. Singh. Good morning.
Hello.
Nice interacting on this platform from so.
Yeah, it's different.
Good morning, Dr. Singh. Welcome, Dr. Nishant, Dr. Ishwar here.
Sir, good morning, sir.
I think we have 10-12 minutes to go.
Dr. Nishan, can you just stop sharing your screen? So first we will introduce you. Dr. Vipin is going to introduce you. So thank you, sir. We have time. Most of the sessions that I think most of the share to say hi. मेरा लैपटॉप इसका तो Senior consultant, वो था ना, senior consultant video shoot किया हमने. नहीं तेरे राइट्स होंगे. तू ज्वाइन कर, तूने कर लिया ज्वाइन? जब मैं अभी देखता हूँ, तूने फैकल्टी लिंक नहीं ज्वाइन किया हुआ तूने. एक मिनट. अरे फैकल्टी लिंक आया हुआ, डॉक्टर वेके ना हुआ. अटेंडी तो उनको वो राइट. वेके ना हुआ. वेके ना हुआ. मैं देखो वो कर राइट दे राइट. हाँ नहीं नहीं देखो फैकल्टी लिंक दिया अलग से. नो चलो गुड. चलो गुड गुड ज्वाइन करो. Good morning, Dr. Vipin.
Good morning, Ravi. Very good morning.
We have Dr. Nishant Agrawal online, and we also have Dr. Colonel S.K. Singh.
Morning, Dr. Patel.
Good morning, sir.
Hi, Vipin.
Hi, Nishant. So good to see you in Delhi,
Yeah,
OI.
it's great to see you.
It's late in the evening.
Yeah, almost 10:30.
Okay.
We'll start in the next 5 minutes, exactly at 9 o'clock. उसमें जूनियर फैकल्टी वाले कितने थे? जूनियर को और सीनियर Dr. Nishant, what is this background picture which you have put?
That's so the orange roofs are our campus, and then this in the background is downtown Chicago.
Okay.
Yeah. So this all in the forefront is the University of Chicago, and in the background is the city of Chicago, and then the blue is the lake.
Okay.
The lake is like the size of the ocean, but it's only a lake. Lake
Yes.
Michigan.
Right. Lake Michigan. Yes.
Yeah.
I have been to Chicago twice. Yes.
Oh yeah, so you know it well.
Yeah. Dr. Nishant's CV actually ran into pages, but I could just extract the important part of it in this slide.
Oh yeah.
Good evening, Nishant. Good to see you.
Hi, hello, good morning. It's great to see you. You look great. How are you doing?
Looking forward to what you have to tell us.
Yeah, it should be interesting.
Yes.
Some things to think about. So how are things in India? Things are pretty good.
Well, India is a huge place, but yeah, Delhi is certainly much better in terms of COVID at
Yeah.
least.
That's great.
Hmm.
The US
If
is a
COVID
mess.
lasts, fingers crossed.
Yeah, seems like it's being managed properly. So
I think it's the virus doing what it does and possibly having done all the devastation it could, at least for the time being, we seem to be okay.
yeah,
And how are you?
everything is
Good morning,
good
sir.
here.
Hi, good morning, Dr. Alok. Hi, everyone.
Hi, Dr. Gul.
Hi, how are you?
Good.
Good. So, great. So nice to have you and be again together. I've left Sabdajang. I retired last year.
Well, I didn't know that. Who could have known? But anyway.
So it's going to be a year this month in. So that's it.
So I think it's 9 o'clock. We can start. So it's my pleasure to welcome you all on the third day of Delhi AOICON. We have a keynote address session which will be delivered by Dr. Nishant Agrawal. The session will be chaired by Dr. Vipin Arora and Colonel S.K. Singh. Colonel S.K. Singh is a graduate and postgraduate from KFMC Pune, and he has served in various capacities in armed forces. He was professor at Armed Forces of Medical College, and he was also head of Army Hospital RNR in Delhi. He has special interest in cochlear implant and laryngotracheal injuries. He has been awarded twice in the service. He did fellowship from Harvard University and presently is working as CEO at a 500-bedded hospital in Jhansi. He is a brigadier, but a doctor at heart. And I welcome Dr. Colonel S.K. Singh. The next chairperson is Dr. Vipin Arora. Dr. Vipin Arora is graduate from Maulana Azhar Medical College and postgraduate from UCMS. He has been trained at Columbia University, USA in head and neck surgery, and he is a well-known faculty, and he has been organizing lots of conferences and workshops on head and neck surgery in collaboration with University of Chicago. He is a dear friend, and I welcome Dr. Vipin Arora. Please, you can start the session. Dr. Vipin, you can introduce Dr. Nishant.
Yeah, sure. Nishant is now a very known figure in Delhi circle. And for the sake of completion, I will introduce Nishant. And Nishant has been trained at Johns Hopkins University of Medicine in Baltimore, and he has done his postdoc fellowship in molecular genetics from Johns Hopkins University School of Medicine, and his residency is in otolaryngology and head and neck surgery is also from Johns Hopkins, and he trained in head and neck surgery at Memorial Sloan Kettering Cancer Center, New York, and completed his fellowship in 2008. He has more than 120 publications with H-index of 47 and more than 17,000 citations. So that is huge. So I invite Dr. Nishant for his presentation.
Thank you, Vipin. It's great to be back with friends. Although unfortunately we're remote this year, but hope to see everyone in person very soon. So I hope you can all see my slides. So today I'm really going to discuss some unknowns in the field. We're seeing an increased incidence of limited factor oral cavity squamous cell carcinoma. I'm going to talk about some things that we take for granted, but really have fairly weak evidence margins. And I think things that we think we have very high level evidence for post-operative considerations for adjuvant treatment, but I think we really don't. Some controversial issues, including chemoradiation for curative intent oral cavity squamous cell carcinoma, and some translational work that we've been working on with colleagues in India from Tata and from Strand to try to develop a salivary diagnostic biomarker assay for oral cavity squamous cell carcinoma. So this is really food for thought, and hope it's entertaining. So this is the SEER database from the United States. I'm looking at the observed survival, 5-year survival for oral cavity cancer, and you can see it's about 50 to 60%. And then if you look at survival per stage as expected, early stage is almost 90%. And you can see the significant plummet in overall survival from early stage 1 and 2 to advanced stage 3 and 4, where advanced stage 4, the survival approaches about 40%. The smoking prevalence in the United States has significantly decreased over the last couple of decades. And as you would expect, the incidence of oral cavity cancer parallels that decline that we see in smoking prevalence. However, as you can see, there is an increasing incidence of oral tongue squamous cell carcinoma. So despite the overall decrease in oral cavity squamous cell carcinoma, some subsites, including oral tongue, we're seeing an increase in incidence of squamous cell carcinoma. And here, from a study published in JCO about a decade ago, looking at the US population, this was seen predominantly in white males and white females. So we looked at this a few years ago, and then there was a systematic review published last year. We looked at the transcriptome and genome of oral tongue cancer, and the patients were social drinkers and non-smokers. And the only thing we were able to identify was a smaller incidence of P53 mutations. But with our transcriptome analysis looking at RNA, we weren't able to identify a genome, a viral genome that could be the etiologic factor. Other groups have also looked at this. And the systematic review included 13 studies of about 130 patients. And from the systematic review, the P53 mutations were actually the most commonly evaluated in mutated genes. And only our study reported a significantly lower mutation of P53, while 9 other studies reported no difference in the prevalence of P53 mutations. And really no other mutations were found specific to this cohort. So this is really an unknown in our field. So what we are seeing, and this is more anecdotic than really causative, and we're seeing a pretty loose association with dental hardware and dental restoration with oral cavity squamous cell carcinoma in non-smokers and non-drinkers. So we looked at our data at UChicago and published this a few years ago, where what we were seeing was adjacent metal restoration adjacent to the tumor. So you can see here an A, B dental restoration, with cancer adjacent to it, dental restoration up here with adjacent cancer, and same thing, dental restoration here with a gingival alveolar squamous cell carcinoma. These are all patients who are non-smokers and social drinkers. And here you can see after a marginal mandibulectomy with this amalgam restoration, and here the adjacent tumor next to the dental restoration. So then we divided our cohort into by age groups, younger age groups, 18 to 50, and older age groups, 51 and above. And as you can see, what we were able to identify in the younger age groups was patients who had braces. So generally, cancers take about a decade to develop. We see patients in their 30s and 40s who have oral tongue cancer, non-smokers, non-drinkers. And most of them get braces in their teenage years. So from a temporal standpoint, it does make sense. It takes about a decade to develop, and that's when we see these patients. In the older age group, we saw a higher incidence of crown and bridges and partial dentures. The full dentures don't have any metallic component, but the partial dentures do. So we've only proven association and no causation yet. But I think this is something that we should all think about. I know when talking to colleagues all around the world, they are also seeing this increased incidence of oral cancer in non-smokers, non-drinkers. Again, this is does not prove causality, but I think this is, as I mentioned in my intro, just food for thought. So the next topic I'm going to talk about are margins. So we all know what an adequate margin is greater than 5 millimeters, as you can see here. The issue becomes is what is a close margin? And what is the significance of a close margin? So this was an international multi-institutional collaborative study of almost 1,300 patients with early stage oral cavity squamous cell carcinoma. Positive margins in blue were defined as presence of tumor cells in the resected edge of the specimen, so obvious. Close margins in green were defined as the presence of tumor cells at a distance less than 5 millimeters. And then clear margins were defined as free margins of at least 5 millimeters. So if you look at two retrospective studies, one out of MSKCC, another one out of University of Iowa, MSKCC in about a 400 patient study proposed that an adequate margin is 2.2 millimeters versus the University of Iowa study with also about 400 patients, 432 proposed an adequate margin to be 1 millimeter. The second area of controversy is where do you take your margin? Is it specimen-derived margins or tumor bed-derived margins? And this was a study, a prospective randomized control study that looked at specimen-derived margins versus tumor bed margins and concluded that specimen-derived margins were more reliable than tumor bed margins. The concern though with the studies, I don't know if any of you have tried to send the specimen for margins. From a pathology standpoint, it's a huge endeavor which takes an extended period of time versus a tumor bed margin, which they can process much quicker. So although we know what is better, the practice hasn't really evolved and has been uniformly adopted to have margins from the specimen versus the tumor bed. So now I'm going to talk about post-operative considerations. So for post-operative treatment, the EORTC 22931 and the RTOG 9501 trials established adjuvant chemoradiation with high doses platinum and radiotherapy as the standard of care in high-risk patients with squamous cell carcinoma. The EORTC study randomized over 300 patients who underwent surgery to RT or CRT. It had a median follow-up of 5 years. The RTOG randomized about 450 patients after surgery to RT or CRT with a median follow-up of almost 4 years. The EORTC study defined high-risk patients as those with T3, T4 disease, positive surgical margins. And again, we talked about surgical margins, and I'll talk specifically how these two studies talked about margins. Extranodal spread, and I'll discuss sort of what does extranodal spread actually mean. Perineural lymphovascular invasion, vascular tumor embolism, or those with oral cavity or pharyngeal tumors with level 4 nodal metastasis. The RTOG 9501 trial defined high-risk patients as patients with positive surgical margins, 2 or more involved regional nodes or extranodal extension. So already you see the studies are different. An analysis at a median of 46 months of follow-up showed that chemoradiation improved local regional control and disease-free survival, but not survival as compared with radiation therapy alone. And then here you can see the trials, the outcomes for progression-free survival, the local regional relapse, and the overall survival for the EORTC on the top half of the slide, and from RTOG from the bottom half. So the trial showed that chemoradiation improved progression-free survival, local regional control, and overall survival as compared with radiation alone in these high-risk patients. And I already talked to you about what was defined as high risk in EORTC. In RTOG, at an analysis of 46 months, showed that chemoradiation improved local regional control and disease-free survival. But you can see the p-values here, but not overall survival. So the p-value here is 0.19. And then the other question, sorry. So despite these differences in these studies and the outcomes of these two studies, a comparative analysis was with pooled data from these studies supported a consensus that the chemoradiation benefits only patients with extranodal extension or positive margins. So when you did a Venn diagram, the positive margin extracapsular extension was common between the RTOG and the EORTC studies. So this is an example of extranodal extension. This is the capsule. This is extranodal extension here. So the orange or the red outlines your extracapsular extension into fibroadipose tissue out of a lymph node capsule. And this is a nice way to think about extranodal extension, where we know 3 and 4 ECE grades are clinically significant and associated with poor outcomes. The question really is, what's the significance of 1 and 2? And again, the EORTC and the RTOG studies did not necessarily define extranodal extension. And the way these studies defined positive margins were also different. So the RTOG defined positive margins as extension or microscopically involved margins of resection. So that was a positive margin. The EORTC study defined and pooled the closed and positive margins as less than 5 millimeters. So if the tumor was within 5 millimeters of the margins, the resection margins were considered to be closed. So again, different studies, but a pooled analysis was done, although the data was very different. So really these studies, the EORTC and the RTOG, was really comparing oranges and apples. And even if you read the combined study, which provides this caveat, so subject to the usual caveat to retrospective subgroup analysis, our data suggests that in locally advanced head and neck cancer, positive margins and extracapsular extension are most significant prognostic factors for poor outcome. So we took this as gospel that we add chemo for positive margin extracapsular extension. But these other high-risk things, such as stage 3-4 disease, PNI, vascular embolism, low-level neck disease, really, we consider intermediate risk, but we don't have the highest level of evidence to say that we shouldn't add chemo, especially in the setting where our survival is only about 50% in these patients. So again, oral cavity overall survival is 50%, which is stage dependent. And until the 1990s, the standard treatment for locally advanced laryngeal cancer was total laryngectomy. And then when the VA study was published in New England Journal of Medicine in 1991, there was significant controversy of using chemoradiation for curative intent for advanced stage laryngeal cancer. So this was a study where 332 patients were randomly assigned to receive either induction chemotherapy or, and radiation therapy, or surgery and radiation therapy. And you can see the induction chemotherapy and radiation therapy is the solid line. The conventional laryngectomy with postoperative radiation is the dotted line. And the survival at 2 years was 68% for both groups, with a median follow-up of about 33 months, so suggesting that the outcomes are similar, and we can save larynxes. And then this was the RTOG 9111 study that demonstrated about 88% laryngeal preservation rate with CRT, and really no difference in survival per the arms of concomitant CRT, induction CRT, or radiation alone. And here you can see we tolerated a fair amount of toxicity related to chemoradiation for the treatment of advanced stage laryngeal cancer. So my reason to bring this up is really to look at this as an analogy for oral cavity. Chemoradiation for oral cavity squamous cell carcinoma is a very controversial topic, but with a survival of 50%, we should not really accept the status quo and challenge it. So this is what we've been doing at UChicago with advanced stage oral tongue squamous cell carcinoma that would need a near total or total glossectomy, which is from a patient perspective as devastating as a total laryngectomy, pretty significant change in their lifestyle. So we use induction chemotherapy and definitive chemoradiation. This is just one example of a patient before treatment and then after treatment. So some limitations of using chemoradiation in the oral cavities: treatment-related toxicity, really osteoarthritis necrosis, concerns related to treatment efficacy. There's a lot of studies out there, although imperfect, that suggest that this is not effective. And then a lot of studies in the past have used definitive chemoradiation as an approach for unresectable disease. So a huge bias has been introduced in the literature. So our approach is for advanced stage oral cavity cancer over a decade is to use induction chemotherapy followed by definitive chemoradiation. And these are the baseline characteristics. I want to highlight that all of these patients had advanced stage disease that was driven by both T classification and N classification here. So this was very high volume disease. And this was our overall survival and our progression-free survival with almost 6-year follow-up. So overall survival of about 63% and progression-free survival of about 60%. And again, if you compare the results from the UChicago experience versus sort of the public database for advanced stage disease, you see a pretty significant improvement. We looked at regression analysis for overall survival, and despite there being changes in technology, there was really no significant difference in a couple of decades that we compared. In terms of ORN, which is the most concerning toxicity related to chemoradiation, our incidence of ORN was about 20% of patients who required surgery. And on regression analysis, the flora of mouth was significantly associated with a higher incidence of ORN, which we would expect. So here you can see about 47% incidence of ORN for flora of mouth primary tumors. So this is our multidisciplinary team at UChicago. And really the multidisciplinary management of head and neck cancer is, I think, what has made us improve our outcomes. And something that our team has been working on, given the significant difference in survival from early stage disease to advanced stage disease, is developing biomarkers in which where currently we treat patients with the same treatment with varying efficacy and actually in some patients some harm, where we can develop biomarkers and personalized treatment so everyone has a positive effect against their cancer. This is data that everyone is aware of. This is published in 2015 from the Cancer Genome Atlas. And the Indian consortium also published the data from gingival buccal head and neck squamous cell carcinoma, very similar outcomes. But P53 is the most commonly mutated gene. You can see CDKN2A, FAT1, caspase-8, PIK3CA, Notch1 are other highly mutated, recurrently mutated genes. In tumors basically from around the world, despite risk factors being smoking, betel nut, or alcohol. So again, these genes are P53, CDKN2A, Notch1, FAT1, PIK3CA, caspase-8, and HRAS. So our goal was really to develop biomarkers that could be detected in saliva or plasma of patients, looking at salivary DNA. We've also developed an assay for HPV, which I won't talk about in this talk. I think it's less relevant in India, but an HPV quantitative plasma assay, which we're going to start using for treatment de-escalation. So this is our study published in 2015, where we looked at all sites of the head, neck, oropharynx, oral cavity, hypopharynx, and larynx, looked at tumor DNA and HPV DNA, both in plasma and saliva of patients. And we found that when we had both plasma and saliva, the tumor DNA was detected in 96% of 47 patients. I want to bring your attention to the oral cavity, where we were able to detect 100% of the time somatic mutations in the saliva of patients with oral cavity cancer. So this is really exciting for us. And then we decided to delve into this a bit deeper. So this is a study which we performed with, again, collaborations from Strand and Tata, looking at patients, 121 patients with matched primary tumor and oral RENs. We also had healthy controls. And here we sequenced the primary tumors and then looked at concordance with matching saliva. And again, we used our negative controls of healthy individuals. So based on publicly available databases, we came up with 7 genes that we thought were recurrently mutated and developed a targeted gene panel with p53, FAT1, and caspase-8, HRAS, CDKN2A, Notch1, and PIK3CA. Most of these are tumor suppressor genes with the exception of PIK3CA and HRAS. And Notch1 we think functions as a oncogene, as a tumor suppressor gene in head and neck squamous cell carcinoma. And these are the results of our targeted sequencing of these 7 genes of primary oral cavity squamous cell carcinoma. And as expected, p53 again was the most commonly mutated gene. And if you compare our results in green with publicly available data, it was very similar in terms of the incidence of mutations in these 7 genes. Then we looked at the concordance, so really this was the objective of our study, to look at the concordance of the primary tumor and saliva. And overall, we had a concordance of about 93%, which was higher in advanced stage disease and lower in early stage disease. And then here on the right, was a lollipop plot looking at the primary tumor above and then the saliva below. And you can see these are almost mirror images of each other for the 7 genes. And then you can see the percent concordance increases up to Notch1 at 93.4%. But we thought it was important to include HRAS and PIK3CA as they're the only 2 known oncogenes with potential targets. So really our proposed application for these biomarkers is to develop an assay for early detection, including pre-malignancy, and we have an active study that's funded by the NIH to look at pre-malignancy in the oral cavity. Monitor during treatment, including looking for emergence of resistance, and surveillance at the end of treatment to detect minimal residual disease or recurrence before it's clinically evident. So in conclusion, I hope I provided some food for thought. This really, the limited factor oral cavity squamous cell carcinoma is becoming a pretty significant deal with increasing incidence and really a known etiology. Margins, which greater than 5 millimeters is straightforward, less than 1 millimeter is straightforward, but what do we do with 1 to 5 millimeters? Postoperative adjuvant treatment, agreed for positive margins, but these studies define positive margins differently, and agreed for extracatheter extension. But what do we really do with these high-risk features in the setting of 50% overall survival? Definitive chemoradiation, very controversial, but we've had a couple of decades of experience showing that this is fairly effective. And then some exciting translational work and development of biomarkers for early detection, monitoring, and surveillance. So thank you all for your time. If you have any questions, my email is na@uchicago.edu. And I appreciate everyone's half an hour in the morning and hope to see you all soon in person. Thank you.
Dr. Nishant, we would like to utilize your presence here by asking the audience in case they want any further clarification or if there is any doubts which you would like to clarify. Although conventionally it is a keynote, but we would like to explore your availability here.
Sure. I think there's much more wisdom in the audience than here. Happy.
Dr. Nishant, can you just stop sharing your screen?
I think we have a question from Dr. Akshat Malik.
Sure.
Hi, sir. Good morning. Dr. Nishant, wonderful presentation. Thanks a lot.
Thank you.
I wanted to ask you, like you showed the results from MSKCC and University of Iowa regarding margins. So can you tell me like what whether that has changed your practice out there in Chicago, or you are still following the 5 mm margins?
So I'll tell you, Akshat, we discussed each of these cases at tumor board, and it becomes very hairy for us with the 1 to 5 millimeters and what we do. Generally, there's other high-risk features. We do have a lower threshold to add chemoradiation for the 1 to 5, but this is not. We don't go by the MSKCC of the Iowa data of 2.2 millimeters or 1 millimeter. We discuss each case individually, look at the pathology, look at the other adverse and intermediate risk factors, and then decide on adjuvant radiation versus chemoradiation.
Right.
I think this is something we have to figure out in the field, though.
So actually, I was there at Tata previously, and there we analyzed data for buccal mucosa. We have published margin analysis millimeter by millimeter for buccal mucosa cancers. This was published in EJSO after these two studies came out. And at least in our subgroup of patients, we realized that definitely 5 millimeters are required. We didn't see any.
How many millimeters, Akshat? How many millimeters?
Five, more than 5.
Okay.
Yeah. You can check it out. It's there on EJSO. So that's why I was wondering whether you guys have changed your practice or if you're still following the same. Okay.
No, we haven't changed it. We just discuss each case, and I think we fight a lot about it. It's highly debated.
Great. Thanks a lot. And have you been using SNB also, or that is still in trial setting out there?
Sentinel lymph node biopsy?
That's correct, yeah.
We use it. Yeah, I think, the definitive data is from Tata suggesting elective neck dissection improves survival. But I think sentinel node, there is growing evidence for it, and there's an active clinical trial that's comparing the two, which I think will provide a definitive evidence. But we offer it to our patients, really elective neck dissection versus sentinel node. And I think both are really good options.
For the sake of time, I think we can finish the session right now.
Thank you so much, Dr. Nishant. And there are few food for thought, especially the dental hardware and its association, which we have talked about. And future lies in the biomarkers. And we would like to appreciate in the usual manner by, although on the virtual platform, clapping, I don't know. And thanks a lot for a lucid and a very educative presentation. Thank you so much.
Thank you all.
Thank you, Nishant. Thanks a lot. Good to see you.
Thanks.
Thank you, Dr. Nishant. If you would have present here physically, we would have felicitated you with the certificate and the medal. But since it's a virtual conference, we will definitely mail you the certificate. Thanks a lot for joining.
Thank you.
The next session is the invited talk session, and it will be chaired by Dr. Divya Agrawal and Dr. Gul Motwani. Dr. Divya Agrawal is presently working as senior consultant and head of the department at Central Railway Hospital, New Delhi. He is very much academically oriented, and he has a DNP program running at his institution under his leadership. Next, we have Dr. Gul Motwani. Dr. Gul Motwani has superannuated recently from Safdarjung as head of the department of ENT. And I invite both the chairperson to session to chair the next session.
Vijay, your camera is not launched properly. Hello? I think there's some problem. I think there's some. Oh my God. Hi, good morning, everyone.
Good morning, Dr. Gul.
Yeah, I think there's some issue in my this thing. Suddenly it has cropped up. So I request Dr. Agarwal.
Just a minute. Just a minute.
Just a minute.
Wait for a minute. We are going to project the details of the next speaker.
Yeah.
Next slide.
Your camera is not installed properly.
Next slide. ये वाली ना, इसको project कर। Share किया मैंने? Share। इसको। ठीक है। एक मिनट। बस ना। इसको share करना। नहीं ऐसे नहीं होगा तो करना पड़ेगा आते ये वाला है ना क्या
So good morning. Good morning, everyone. And the next talk is by Dr. Alok Thakkar. I'm sure there's no introduction needed. He's a very renowned person, and he's head of the Department of All India Institute of Medical Sciences, Delhi. And he's got fellowship neurotology and skull-base surgery from UK in 2003. His special interests are neurotology and skull-base surgery, and he has had more than 300 publications. And I'm honored to chair this session, and I invite Dr. Alok Thakkar to kindly start his presentation. Dr. Alok Thakkar, please.
So thank you, Dr. Motwani. I'd like to share my screen here. So if I may be allowed to, I'm told that you cannot quite share your screen while the other participants.
I think there's some. Please go ahead, please.
Now I can, yes. So thank you for the introduction, and of course, thank you to Delhi OI, particularly Professor Ishwar Singh and Professor Ravi Meher for the opportunity to present this work. So this is precipitated by Dr. Ravi chancing on the laryngoscope and noticing that we had made it to the cover in a recent publication. And yes, it's an important publication, I think, which has more potential at the moment. I do hope this would go further, which is probably why the laryngoscope thought that they would put it on the cover, so to say. Of course, it makes for a good picture too. So this is a nuclear medicine scan which was done for angiofibromas, and we had a small case series of 19 patients, wherein we sort of found that for the Dodonok scan, you get 100% uptake with this. And that obviously opens up the door to potential applications. But let me take you through a little bit of the background, and then we will sort of discuss maybe further as to what use we may find for this as time goes on, or what use we have found for this really. So let me first say that we have been active in this area for a fair length of time, and this is a small section of the team at our institution that gets involved with angiofibromas, and you would recognize a lot of faces here. But to introduce you to some of our colleagues and from other departments, so we have Ashish Suri from neurosurgery, we have Professor Rakesh Kumar from nuclear medicine, of course we have Professor Rakesh Kumar from ENT, but we also have Professor Rakesh Kumar from nuclear medicine, who has very largely led this work. We have colleagues from anesthesia, Professor Rewari, we have Dr. Ashu Seth from radiology, And of course, among us, we have here Dr. Prabhu Saktivel. Prabhu is well known to all of you. He was trained at the Maulana Azad Medical College and then subsequently trained with us in head and neck surgery and oncology when he did his MCH. And largely this is his work and his idea really. So moving forward, this is something that you may well be aware of. I have actually spoken about it ad nauseum on many occasions, because this is really a protocol of how we treat juvenile angiofibroma. And this is a protocol which has been in place since about 2003, when embolization was introduced in our institution as a routine for all patients about 2000, 2001, largely by the efforts of Dr. Ashu Seth. And of course, we had by then worked out a clear scheme as to how we approach these tumors surgically, be it a stage 1 tumor or a stage 3 tumor. And it was always the same steps, which we thought really was the key to any operation and perhaps to minimizing recurrences. Around 2005, we started our work with flutamide. Flutamide is an anti-androgen, new generation anti-androgen, which we were using for tumor shrinkage. It is good from the point of view that it is easily administered orally, and it is good from the point of view that it being a receptor blocker, it actually causes little side effects in terms of feminization or in terms of loss of libido. And to our experience, has been a good drug which can often shrink the tumor before you take the patient up for surgery. So we use it as pre-surgical optimization. And in our initial paper, which has done reasonably well in terms of citations in this small area, we could tell that patients who were pre-pubertal, that is the areas you see in blue here, didn't quite have that dramatic responses, but in patients who were post-pubertal, you could anticipate some very dramatic responses in terms of the regression that you could notice in the tumor. And we also sort of went on to see that in many ways, the response that you had with this drug was related to the testosterone levels in the serum. So it made a lot of sense to use this for patients who were post-pubertal and had enough testosterone in the serum. And we have been doing this for a fair length of time. And as you can see here, pre-flutamide and post-flutamide pictures, that you can anticipate some regression in the tumor. And this helps because if you have a tumor which sort of shrinks away from the ICA and its intracranial component, or if you have a tumor which shrinks away from the temporal fossa, then you can sometimes get away with a less radical approach and of course a much safer approach. So flutamide is now standard for our post-pubertal patients. And as this protocol has developed, we have also validated that paying attention to the Vidian canal is a key element of angiofibroma surgical treatment, because you do have involvement of the Vidian canal radiologically in about 90% of the patients, and even in the odd patient where radiologically it seems okay, if you look at microscopically, you can still find tumor in the Vidian canal. So it is now again standard practice to drill the Vidian canal. This is a patient who's had an endoscopic excision many, many years ago. And as we drill the Vidian canal, you get a little bit of a bleed because you open up the artery in the Vidian canal, and also perhaps some tumor there, which gets better cleared. In fact, we have validated that if you drill here, you do cut down on recurrences very dramatically. So with this general scheme in place, we sort of thought that we had cracked this, so to say, and we were now at a situation wherein recurrences were almost fully controlled, so to say, but perhaps that was the illusion of youth or the overconfidence of youth. As time went on, we discovered that that wasn't quite the case. We were having recurrences now and then. And yes, these recurrences were occurring because that is the nature of the disease. This is ultimately a tumor which is unencapsulated, and of course, there can be microscopic residue. And also because perhaps our practice has changed over the years, wherein we get involved to a very large extent with mainly very large tumors, stage 3 tumors, not so many stage 1 and 2 tumors. And the other thing that came out was that as you do MRs, previously we were in the illusion that you're having no recurrences because much of follow-up was by endoscopy and MRs were not usual for the follow-up. But as we started doing more and more MRs, we of course found that we had more recurrences, and we also went on to find a fair big degree of ambiguity in the MR scan in terms of not quite being able to discern on the MR as to whether this is actually recurrence or not recurrence. And this is a familiar conundrum to people who are involved with JNA. You have a scan such as this, wherein you see some bright enhancing signal in the sphenoid or the lateral recess or the pterygoid base, and you're never quite sure that this is reactive tissue or polyp or inflammatory granulations, or is this tumor? And this is not just us. Everywhere in the world, this is a problem with the MR that you can't quite tell as to whether this is really, and it's vital to know because, of course, if you have a residual tumor in the skull base, you need to do something about it, and this can be difficult. So this is the opinion from the European group. Professor Nicolai has by far the largest experience in Europe, I would say, and publishes extensively. And they also have sort of noted of the same conundrum wherein it's difficult to know. And in fact, their policy has been to do an MR immediately after surgery, within the first 72 hours, because they say that is the best time to look for residual disease. And you can't quite look for residual disease after that as inflammation sets in. It does become difficult. So this is the background on which we talked about the PSMA scan. So Prabhu joined us as an MCH candidate sometime in 2017. And we were obviously looking at what area of research you would like to get involved in. And this was his idea that perhaps we could use a PSMA scan. So the PSMA is a prostate-specific membrane antigen which is found in prostate tissue, and this is a scan which is used primarily for metastatic workup in patients with CA prostate. But it's a bit of a misnomer. It's not quite an antigen which is specific to the prostate. It's a transmembrane protein, which is also seen in other tumors, especially tumors associated with neoangiogenesis. And when Prabhu talked about it, we did see that there might be potential into it. And so over the next few years, we have spent some time in exploring this scan as a follow-up scan for patients with angiofibroma. So as everybody is fairly well aware, angiofibromas are a frequent part of our practice at our institution. We have a kind of special interest there. And so the next patients that came up, we started to do this scan for these patients. And certainly, this is one of our earlier publications where you can see that the angiofibroma brightens up and is seen quite easily on the PSMA scan. We followed this up with a prospective study on 25 consecutive patients, wherein we did the PSMA scan for patients undergoing or coming up for surgery. And as I had previously said, these were mostly patients with fairly extensive disease. So 17 of 25 had stage 3 disease. And that's the nature of our practice. Most of them had open operations, either with the transmax, or either with a maxillary swing or a lateral infratemporal fossa fish type D approach. This is really the technical issues of the PSMA values at various sites in the head and neck, which is really to say that which is really the data on which the following statements are based. That is, the PSMA scan was universally positive in all patients with juvenile angiofibroma, and it sort of showed all the tumor extensions that was shown in the MRs. It was almost as good in terms of limiting tumor extensions or showing us tumor extensions. It was particularly good for the CNS because the brain does not show up on the scan, and so it's particularly good to see any extensions into the brain. And you can see this, obviously this one is too large, you can't quite miss it. So you can see the cell has expanded and the tumor is going suprasellar, and then you can see it in the superior orbital fissure and the pterygomaxillary fissure, intratemporal fossa, all the areas that you tend to see. we also needed to work out as to what would be the best cutoff in terms of giving a positive versus a negative report. And the nuclear medicine guys worked this out by saying that comparison with the CT paraspinal muscles was the easiest and the best. But there were a couple of other small issues. The resolution certainly is not as good as MR, so it doesn't quite replace MR. It's a good addendum, but it doesn't replace MR. And yes, there is very bright uptake in the salivary glands, in fact, brighter than the tumor. So you see it in the parotid, you see it in the sublingual and the submandibular glands. You also see it in the lacrimal glands, and you also see it around the eustachian tube. So these are potential for false positivity because you would see positive uptake here. We also notice a decreasing intensity as patients got older, and that sort of is, it's not statistically significant, but it supports the time-honored notion that perhaps tumor gets less vascular and more fibrous as patients get older with this tumor. Well, that was the initial report. We followed it up with pre and post-op reports. So this is a cohort of 22 patients wherein we have done pre and post-op scans for these patients. And again, you can tell that the excision of tumor doesn't quite show tumor anymore and or a PSMA positivity anymore. But there were fair amount of situations wherein you would see positivity in the MR, which would sometimes be corroborated by the PSMA scan and sometimes not be corroborated by the PSMA scan, the arrows that you see here. And this was fairly frequent. So we looked at the relative accuracy of both these techniques, the MR and the PSMA scan for follow-up, and that was really the impetus which had set us out to looking at the radionuclide scan as a means of scanning patients with angiofibroma. We really don't have a problem in the pre-op diagnosis. It's in the post-op situation that we tend to have issues. And in the post-op situation, the MR with gadolinium was giving us difficult situations where you're quite sure as to whether there was tumor or not, but the PSMA scan was so much better in telling us as to where the tumor existed and where it didn't. And if you look at the sensitivity and the specificity of the test, and you can obviously tell that the MR doesn't do very well, but the PSMA scan does very well, 100% sensitivity, 100% positive and negative predictive value. So moving on, this is another report. The first report was on patients on a consecutive cohort of follow-up patients. This is on patients who were a high risk for recurrence and actually presented with either epistaxis or things of that sort, wherein we were worried for residual disease. And again, the specificity of the MR is not very good in this situation, but the PSMA is seen as 100% sensitive, so and specific. And similar issues, you see the MR gadolinium throws up a difficult possible of or suggests to a recurrent residual lesion, but you don't quite see it on the PSMA scan. And that really is the essence of this talk. This is really what we are saying, that in terms of MR, this is a better way. And you do have difficult situations wherein patients obviously and physicians are worried. And if you can do a PSMA scan, you might avoid a skull base operation. So what next? There was this report which some of you might have seen, which sort of made the lay press and was quite and had a brief era of wide publicity in the oncology circles, wherein a new salivary gland was talked about, the tubarial salivary glands, by colleagues from the Netherlands, who were again doing PSMA scans and were looking at this positivity that we were noticing in the salivary glands and the nasopharynx, what we call the eustachian tube. But they were smarter than us. They went back and looked at the human cadavers in a couple of patients and could actually say that there were major salivary glands in the nasopharynx. So they identified a new salivary gland in the nasopharynx, not a minor salivary gland, but what they called a major salivary gland, and called it the tubarial salivary gland. And of course, when this report came out, we immediately knew why we were having a false positivity pickup at the eustachian tube area. And we could corroborate that study immediately because we had the data available with us. And we also showed that our patients too were showing the same things. We again made the cover of another journal then. This is the paper that Dr. Ravi Meher was talking about. This time we have moved on from doing a PSMA scan to a Dotanox scan. This is a somatostatin receptor scan. It's more widely available, generally used by us for paragangliomas. And again, we're going down the same route of first showing that there is universal uptake by this scan on the tumor. And now we're in the stage where we are trying to say that this can be a good follow-up evaluation scan and maybe far better than the MR. It's a little bit different from the PSMA scan because there is no uptake on the salivary glands. You can see that, but there is very intense uptake in the pituitary. So really another scan to play about. This is to say that the PSMA, the Dotanox scan, we are now merging with the MR rather than with the CT. So we can do a Dotanox PET MRI, which gives you the advantages of both high resolution and functional imaging. So you get both high resolution and specificity of functional imaging. And perhaps this is the future as to how we would be looking at these patients. So thank you. I conclude. All I say here is that in comparison to our protocols for pre-surgical assessment and how to do the operation or the steps of the operation, we now have a clear protocol for post-treatment surveillance, and that is as to what Dr. Prabhu has called the post-operative angiofibroma radionuclide study, which is the Paris protocol as he calls it. And this is probably the best way to move forward in terms of post-op surveillance because it has a 100% sensitivity and 100% specificity. So thank you from all of us. And as I said, particular thanks to Dr. Prabhu, whose work it really is. I'm just an associate. Thank you.
Thank you, Dr. Alok, for a wonderful, beautiful, and a very clear presentation on PSMA antigen and all. It has really opened up a new window for all the ENT surgeons as to decide about the recurrence or the scar tissue in post-op patients of juvenile nasopharyngeal angiofibroma. And it has you have told us about a tuboaerial salivary glands, and of course a new Dotanox PET scan. And thank you so much. And we are very fortunate to have you with us. Thank you so much.
Thank you.
Thank you, Dr. Alok. Dr. Alok, can you please stop sharing the screen? Dr. Alok. Okay. Next. Our next speaker would be Professor Amit Kishore, and he would be speaking on bone conduction auditory implants, current trends. So Dr. Amit Kishore doesn't need any introduction, but still I must go through it. So he's the Director and Chief Consultant ENT at Apollo Hospitals. He is a graduate from AFMC Pune, and he was awarded a medal for ENT. He has done his fellowship at the Royal College of Surgeons at Edinburgh, as well as the Royal College of Physicians and Surgeons of Glasgow. Received special training and experience in microscopic surgery, ear surgery, neurotology, cochlear implants, endoscopic sinus surgery, and pediatric ENT at various centers in the UK, Europe, and USA. And that's a lot of experience and training. He is the lead surgeon for the cochlear implantation at Apollo Hospital. He has over 700 cochlear implants to his credit, which is great. So, Dr. Amit Kishore, please.
Morning. Good morning, everyone. Thank you very much. I'm just trying to see. There is an issue here with screen sharing. It was working. I'm sorry about this. Anyway, I will take a minute or two. So try again. So yeah, thank you, AOI, and thank you very much to Professor Ishwar Singh, Professor Meher, to give me the opportunity to share this with you. Is my screen visible? Is my screen visible?
Yes, sir, it is visible.
Wonderful. Thank you very much. So thank you very much again for the opportunity. And so I was asked to give a quick overview to our colleagues on the current status of bone conduction auditory implants. There's a lot to cover, and I will try and stick to time. And it's just to give us all an overview of where we stand today. It's a tall order to follow Professor Alok Thakkar. But fortunately, it's a different topic completely. So I think I'll escape from that. So we know that in auditory implantation, we have a huge number of options depending on what we are trying to deal with, right from middle ear, cochlear, brainstem, and of course the bone conduction implants, which is the topic of this morning. So I don't have to tell you that we do hear through bone conduction, and that's how this technology is harnessed and is utilized. And we are all aware that this is not new for us. There are a variety of bone conduction devices, both wearable, external wearable bone conduction devices and implantable bone conduction devices that have been around for our patients and clients for a number of years, and these advances keep moving on. So that's the whole idea of this. So I'm going to sort of talk about a few different aspects so that we get the complete overview once we mix and match it. The first thing is the type of technology. So lots of things have been tried, things have died natural death, but what we have today are two types of technology for an active bone conduction implant. And the first is the standard electromagnetic device, which is basically an electric current being passed into a combination of a coil, which creates a magnetic flux in the adjacent magnet. And when you combine that whole adaptation into the bone, you're going to be able to create vibration that is delivered via bone conduction to the cochlea. So that's how a standard electromagnetic hearing device works, standard physics there. We are also aware that there has been in the past the piezoelectric devices, and the piezoelectric devices work on a different principle. There's a piezoelectric crystal, and the piezoelectric crystal changes its volume when an electric current is passed through it. And by doing that, you can create a vibratory signal, which again, if coupled to bone, can drive the cochlea. The slight advantage of the piezoelectric crystal over the electromagnetic is that this technology itself is MRI compatible, provided, of course, it's not connected to any other magnet. So, but the crystal itself is compatible to MRI. And this has been also used in various other technologies across the board. So in terms of technology or driver, shall we say, we have two options that we've talked about. Now, how do we deliver this energy in an implantable device? There are two ways. There is a percutaneous way where the driver is attached via a fixation fixture, or basically a fixation screw into the bone onto a plate, and the driver is external, and that is driving the bone through this screw. That is a percutaneous system. You are going through the skin, and of course, when you go through the skin, you do have the issues that we have in our part of the world with infections and granulation, around this point. So you have a second option called the transcutaneous system, where you are not violating the external skin. There is an external processor and there is an internal processor, and the active component is placed probably within the bone. So the delivery can be percutaneous through the skin, or transcutaneous where the skin is intact. So that's the second combination that you have. And the third is an active device or a passive device. So what do we mean by an active device? By what we mean is that the active transducer is actually placed within the bone. So be it the piezoelectric crystal or be it the electromagnetic FMT or whatever it is, that's placed within the bone, and there is an external processor on the outside. In a passive transcutaneous device, of course, we are not violating the skin, but the difference here is that there is internal fixture with a magnet or a plate, and there is an external magnet. So we are not violating the skin, but the active component is the active transducer is on the outside. So there is going to be some attenuation through the skin if you're using a passive device, but in an active device, which is probably the most effective currently, you do not lose that skin attenuation in terms of sound delivery. So all in all, what do we have in terms of permutation and combinations? So we have the electromagnetic technology, and the electromagnetic technology, which is what we know from the non-surgical, be it the bone conduction transducers on a headband or on the spectacles or on a metal band. But in the surgical electromagnetic devices, we have the percutaneous implant, and in the percutaneous implant, we currently have the Baha Connect system or the Ponto system. These use the fixture and the abutment to go through the skin. You can have the electromagnetic transcutaneous bone conduction implant, which is not the active implant. You have the Baha Attract system, wherein you have the processor externally, you have a screw internally, and then you have two magnets that are sticking to one another, or also the Sophono device, which works on a similar principle. And if you look at the active bone conduction implant, transcutaneous, wherein you have the electromagnetic device placed within the bone, then that's available. That's called the bone bridge device that's available to us from Medel, and the piezoelectric act device is the most current kid on the block, and that's the Ossia device from Cochlear. So we quickly go through some of these that we have using, but before that, standard indication. So for you and I, what are the types of clients or patients that we're looking at that we might want to think be appropriate candidates to counsel for a bone conduction device and possibly an implantable one? The first is conductive hearing loss. This is quite straightforward. You have to have good bone conduction thresholds, and you have a conductive loss for whatever reason, and they will do very well because you're bypassing the middle ear mechanism. You're stimulating the bone conduction directly. You can have, and these are the common ones. The most common, and I think that the most appropriate indication are kids with microsureatresia as an alternative to some form of external or middle ear reconstruction, if you believe that's going to help them, if the Yarsdorfer score is good, etc. But that is one very classical indication for any bone conduction device. You could have other things that we see, could be chronic otitis media, mastoid cavities, discharging ears, failed ossiculoplasties, where we feel that we are not going to be able to give a very good result, or we have tried. And as an alternative to a hearing aid, that might be an option where we find that using a hearing aid is not appropriate because of the discharge or the cavity, etc. Some people have believed that people with otosclerosis can have it. That's not my practice. That's not what I do, but that's an option that you have because, again, you have a conductive hearing loss or a mixed hearing loss in these situations. So, of course, conductive hearing loss, and you can have a mixed hearing loss again with the same pathology. The thing to keep in mind is that all bone conduction devices do have a criteria for minimum bone conduction threshold. So you have to look at, whenever we're looking at bone conduction devices, it is the bone conduction threshold that is important, and the air conduction threshold doesn't have any meaning here when it comes to candidacy. So your bone conduction threshold, depending on the processor or the device you're using, can be for a patient where you're using it on the same side as a pathology, can be anywhere from 40, 45, up to 55 or 60 decibel hearing loss. The 55, 60 for the more powerful processors, but standard processors will amplify anything within 45 decibels across 5, 1, 2, and 3. So that's a standard fitting criteria. The third indication is, of course, single-sided deafness. Again, this is one of the options that we offer our patients, apart from either doing nothing, using a cross device, or we give them a trial with the bone conduction device. in single-sided deafness. And now in a very, very, very select, maybe a cochlear implant. But again, bone conduction devices, standard option for single-sided deafness, provided you have good bone conduction on the other side. Because as we will see, you have to counter the attenuation effect from crossover. You have to have bone conductions within 20 dB on the better side for a patient to benefit from a bone conduction device in single-sided or unilateral sensory hearing loss. So your thresholds on the other side have to be really normal, for that. And they have to have been satisfied from a successful preoperative trial. So the whole idea of unilateral sensory neural hearing loss is that you want to provide adequate amplification. To overcome the head transfer, you do get a 15 dB attenuation, across the ear. And that just allows, if you can manage that, then it allows the person to hear from the other side. So it's a pseudo binaural hearing, but it allows a person to get benefit. Not everybody we see with single-sided deafness actually opts for a bone conduction device, but it's worth one option to consider. So to summarize, when you're looking at our patient clients who might be a candidate, we're looking at the conductive hearing losses. Standard are the atretic ears, particularly bilateral atresia. And of course, we've looked at the people with failed ossicleplasties, draining ears, mastoid cavities, etc., who have a conductive loss or even a mixed hearing loss. As long as your sensory neural thresholds are better than 45 dB, you will get benefit in the mixed hearing losses with a bone conduction implant. And we've looked at the single-sided deafness, but in that case, you've got to have normal or near to normal hearing on the other side. So that's a pictorial representation. Once again, just to give you an idea of what the fitting criteria might be for a standard bone conduction implant for the same side or for single-sided deafness. Now, it's always important, and that's one advantage, is that for our patients to go through a trial, we should not just jump into that unless they've actually tried it. So you can get any form of bone conduction transducer with on a headband or on a bite bar, and you must put it on, get them to do a trial. You can plug the other ear if you want them to get a better experience. You can go ahead and do aided assessments, and they must have a subjective assessment of what it's going to be like before they actually go down that route. So very quickly, just going to quickly go through some of the ones that are available and how we as surgeons would address them. So we've talked about the BAHA systems. The BAHA system, electromagnetic system. We've got the BAHA Connect, which is going through the abutment directly into the bone. It's a percutaneous system, or the BAHA Attract, which is an inactive transcutaneous system, and that's how it works. You've got a magnet on the outside and a magnet on the internal fixture, and that gives you the sound. This is something that all of you know about because BAHAs have been around for a long time. The surgeries have got simpler and simpler by making a simple skin incision, exposing the periosteum, using a drill to create a guide hole into the bone. You want to go to 3 to 4 millimeters, create a countersink into that position and fix the abutment. In the old days, we used to have to thin away the skin, but with the newer hydroxyapatite coating abutments, you do not have to remove the skin because it's been seen that the soft tissue can bind with that hydroxyapatite and you don't get the granulation that you would get. But having said that, so you can avoid this step completely, which is quite a cumbersome step, and you can just go and straighten, suture the skin and put the abutment on. But having said that, in our part of the world, about 15% of our patients still have issues with granulation, infection, overgrowth of skin around this. So the percutaneous system is really not without its problems. But nevertheless, a kid like this, where we've in fact gone ahead and gone for prosthetic ear over a reconstructed ear with the BAHA, that's what it would look like. And you can get pretty decent, post-op thresholds with a bone conduction implant, as you can expect. So that was about the BAHA. The second, we talked about the active electromagnetic system, which is the Medel bone bridge system, wherein the electromagnetic device called the floating mass transducer is implanted into the bone. So it's a little larger device. You have to do a little bit of surgical planning to see whether you're going to go into the sinodural angle or whether you're going to go into the retrosigmoid, depending on what previous surgery the patient might have had. It may have been a vesicular schwannoma surgery or a skull-based surgery or something like that. So Again, the philosophy is that we make a skin incision, we plan out on the CT and on the table as to where we are going to place this. This was a gentleman, for example, I had to do a total petrosectomy and complete exenteration because of a very bad cholesteatoma, which had eroded his cochlea. He was not a candidate for a cochlear implant, but with trials he opted to get a bone conduction device. So you create a well for the FMT, you make sure you get the size right and the position for the osseointegrated screws, and there are 2 of them. You tighten them as you would for any other osseointegrated device, and you place the FMT with the receiver stimulator coil in the appropriate position, and that's what it looks like. So that's what the processor is when it sticks onto the back of the head. And these are the type of thresholds you can get with an active device, and the difference here is that with an active bone conduction device, you do get better high frequency thresholds as compared to a transcutaneous device or a passive device, more of a passive device. It lacks in giving you that high frequency beyond 4 kilohertz. So the latest kid on the block is the piezoelectric system that's come out by Cochlear called the Ossia system. And again, it is an active device because the piezoelectric crystal is embedded in the bone with a fixture here, and the processor is on the external surface, and it's transcutaneous because we are not invading or going to the skin. That's what it would look like. It's a simple surgery as in you would do for a Baha surgery. The amount of drilling and fixture placement is much less. And they have shown that as compared to their own Baha devices, there is additional gain with the Ossia system up to an average of 12 dB more, particularly in the high frequencies. And that's the advantage of an active device, be it Medel Bone Bridge or the Ossia. So yeah, we're good to time. So basically what I've tried to do in this is to give all of you an overview of currently what is available to us and to our patients in terms of bone conduction devices. They are, of course, a preferred option, and we should keep that in mind in certain clinical situations. We've talked about ear atresia, which is a classical one. Of course, a single-sided deafness is an option for those who wish to opt for it. And in certain conductive and mixed hearing losses, that would be an option that at least we can offer our patients. We have the standard wearable, external wearable devices. We know the limitations in terms of attenuation because of skin, the pressure, and the difficulty. So implantable bone conduction devices do provide better comfort and better hearing outcomes as opposed to the other ones, if one can afford them. And we have discussed about the active transcutaneous devices. They certainly have more advantages over the passive ones because in terms of the audibility and the hearing outcomes, and certainly in terms of comparison to the percutaneous system, the advantage is that we don't violate the skin and have the issues with ongoing skin care that we have. So as technology advances, I think we are in a better position today than we were in the past to provide an option to some of our patients with regard to hearing in these situations, and better surgical techniques and better technology allows us to do that. So with that, thank you very much for your attention, and once again the opportunity to share this information with you.
Thank you, Dr. Amit Kishore, for a very lucid talk on a current topic. Now, due to the paucity of time, we wouldn't be taking any questions, and we would be moving on to the next session.
Thank you, Dr. Alok and Dr. Amit Kishore. Thank you, chairperson. I would request Dr. Alokraj to please felicitate our chairperson, Dr. Divya. Thank you. So next is inauguration ceremony. It will be a short ceremony, and we have Dr. Ashal Gulati joining us online as a chief guest. I will hand over the mic to Dr. Deepika, who will compare the session.
A very good morning to one and all. Education is the most powerful weapon which we can use to change the world, and an investment in knowledge pays the best interest. With this, we begin with the inauguration ceremony of Delhi AOICON 2021. I would like to invite Dr. Anup Raj sir, Professor and Head of ENT at Sharda Medical College, Noida, and ex-HOD, Department of ENT, MAMC, for lamp lighting ceremony. I would like to invite Dr. H.C. Taneja, sir, Director Professor ENT, Maulana Azad Medical College, for the lamp lighting ceremony, and Dr. Ishwar Singh, sir, and Dr. Ravi Meher. I would like to welcome Dr. Anup Raj sir, Professor and Head Sharda Medical College, Noida. Now I would like to invite Dr. Ishwar Singh sir to address the audience with his few words of enlightenment. So please.
Good morning, everybody. I welcome you all. A very warm welcome on the 43rd Annual Conference of Delhi Chapter of AOI. A special welcome to Dr. Achal Gulati. Sir, Dr. Achal, we are missing you here.
I know, Ishwar.
Welcome you virtually. Had it been you here, it would have been wonderful. So special welcome to Dr. Achal, Dr. Anup Raj, ex-HOD MAMC, and my senior colleague at MAMC, Dr. Taneja, President-elect, Dr. Ravi Meher, Secretary, and Dr. Rajiv Kumar. I took over as President in 2019, and we organized the clinical meets, and we were about to hold this annual conference in the last week, but on 23rd March, lockdown was clamped and we missed it. So this conference is held after 2 years, and I welcome everybody. So the achievements were, we had conducted all the clinical meets in 2019, and in 2020, which we had declared in the executive as 0 year. So we held 3 clinical meetings online, and 3 webinars were conducted, and one of the webinar lasted for 3 hours. It was well attended, and the attendance in these clinical meetings as well as webinar was much more as compared to the physical one. the things we introduced, 2 awards were started. One was Best Paper Award and second was Senior Consultant Award, Best Publication Award. And we have started the Delhi AOI website. You can access this and the address is www.aoidelhi.in. And the website is going to be inaugurated today and it's almost ready. So through this, you can access the activities and what is all going and all the details will be put on this. We have a very dynamic secretary, Dr. Ravi Meher, and he has ruled 59 new members. So it's a big achievement. Other things, this year we had record number of participants because there was no conference last year. So there was a backlog and 35 participants were there in the Mukut Saria and 36 in the poster presentation. It shows that the residents were also waiting for this conference and they took very active and enthusiasm was there, and that is there. We can see that this conference has been held in hybrid mode. Many of the police are online and I can see so many sitting in the hall. I congratulate Dr. Anup Raj, sir, on getting this lifetime achievement. Congratulations, sir. And I welcome Dr. Taneja, Dr. Vipin to take on the responsibility. Me and Ravi, we have been carrying on for last 2 years, so we are ready to hand over them. At last, I thank all the participants and I thank you so much for your cooperation. If there is some minor hitch here and there, please do excuse us. Thank you so much. Jai Hind.
And now I would like to invite Dr. Manish Munjal, sir. Sir is the senior consultant of ENT at Sargangaram Hospital to say a few words about Dr. Anup Raj.
Life Award सबसे ऊपर WAI 21 ये Life Award एक मिनट भागो ये
Good morning, distinguished guests and faculty. Thank you, Dr. Ishwar Singh, Dr. Ravi Meher. Thank you, Dr. H.C. Taneja. Thank you, Rajiv, and Dr. Vipin, who is also taking over on the new team from the old team, but it is all friends. And the previous team has done such a wonderful job on in the last 2 years, tough pandemic, but kept the highs up by organizing these various online meetings. And we were all benefited by that. We'll all remember that. And I hope that we'll continue to do the things in the future. Well, what a better moment for a person like me who has been entrusted to talk about Dr. Anup Raj, Professor Anup Raj, sir. He foremost is our teacher in Maulana Azad Medical College, and from there onwards, his journey has been unique in many ways, but since it's a lifetime achievement, I would just like to talk a little about his early days also. So yeah. So this is I try to find out what is the basic philosophy that such a popular teacher could have actually in inculcating to his students. Why is he such a popular, enormously popular teacher amongst all of us? Because he never believed in pushing in a fixed type of knowledge onto our heads. He always was the person who says, I'm the guide for you, and I only create the teachings, the conditions in which you can learn. And I think a great teacher is the one who actually helps a student realize the potential that he has or she has. And in that, he takes a back seat. So I thank you, Dr. Anupraj, for this enormous quality which has helped shape so many of our futures and will continue to do so. As I said, sir is now retired. He is superannuated from the director, professor, head rank from Maulana Azad Medical College from the Department of ENT. But he is continuing his teaching journey even today. It all began on 31st October 1951, and that is in Gwalior, Madhya Pradesh. He was born to a district session judge, a very, very distinguished upbringing, as you can imagine how it is to be born in a judge's house. And yet he kept his feet on the ground. He's happily married now with a doctor's spouse, who's also a very successful government doctor in her own right, and two wonderful children who I happen to see in the audience today, Aditi and Varun. They are Dr. Aditi now, and Varun, who is a very successful corporate lawyer. And presently, sir is associated with Sharda University. He is giving his valuable experience to them as the chief advisor, superintendent, and the director in ENT, and he's living in a very well furnished and a great house which he has built with a lot of passion. We all should visit him there. Well, you cannot discount his years from Madhya Pradesh, and he made his early foray into service, not through only education, but through his initiation into Rotary Club activities there. He later on became the president of the Rotary Club Association, held various functions and seminars, and was a very, very natural leader at this, and was also endeared by many leading politicians like Madhav Scindia ji, Digvijay Singh ji of that time. Of course, the journey of professional teaching had to start, and after various stints in Department of ENT at Gwalior, then went into the resident training in Indore. After that, came back to Gwalior and did a fair amount of experience there, and finally joined Maulana Azad Medical College, from where his real journey as an educator started. That was in May 1985. And from there, he joined as an assistant professor, then became associate professor in 1988. Then subsequently became full professor 1993 to 2008. Then professor and head for a very long time, chairman from 2003 to 2015. He was the senior director there and chairman, and was endeared by one and all. And also, meanwhile, kept his work connections back with Gwalior and various places like Varanasi. He is a life member of All India Association of Otolaryngologists, Association of India, Society of Otology, Rhinology, of course, very prominent in Delhi State Branch, and All India Academy of Otolaryngology as well. and is fairly well known in international circles. He was a visiting fellow and consultant to Hauser Institute, NIH, Washington, New York, INEL. He also has been on a member executive committee of MCI, member co-curricular committee, appraiser, permanent appraiser, Medical Council of India, and also very prominent in Diplomat National Board, DMB board also, which is one of the leading exam taking body and in India now. A lot of papers, it will not be possible to tell about all of them, but proud to tell you that right from pathology in earlier years to a lot of research in voice, and especially the biochemical effect of hormones on voice and issues that affect the voice. He has worked a lot hard on that and has publications on it as well. These are his few chirpy snaps from the fancy year. We might think a lot about him as a very serious guy, but he is indeed a very jovial one when he wants to. And some of these photographs are really, really amazing. The right one on top can see Professor Arun Agarwal, I think Professor S.C. Sharma. That's it. Yeah. Yeah, I mean, he can also smile. I just came up. Okay. And sir, and I don't know. PP Singh. Okay, that's PP Singh. My God. Okay, I don't recognize. Wonderful, wonderful. What a snap. These are for posterity, I think. And Dr. Pasi as well. And of course, we at the Mahadev Road residence of Dr. Anup Raj, next to the college, it was the drinking hole and the relaxing hole for a lot of us felt in those days. And sir was a welcome guest, a welcome host, always ready to host us, even if you had a big scolding from him in the morning. It used to be all party time in the evening, and that was the whole gist of the story. You work hard, but you party harder. So thank you, sir, for that. And of course, this is I think the time when he has superannuated. Sir is looking relaxed, and that is quite great to see. Dr. Ishwar Singh is handing him over the bouquet, and that is how colleagues should hand over the baton. It's all a pleasant journey. His highlights of the career, he started many firsts actually. The ORL Journal, if some of you know about the Lifeline Express, it's a unique concept. A lot of people have benefited from surgery on these mobile wheels. And a lot of residents and young doctors have learned surgeries on these Lifeline Express trains. And then, of course, he received the honorary award, the State Service Award in 2001, I think, 2003, from CM Sheila Dixit. And he's been president of Delhi OI in 2001, treasurer 2001 to 3. President, so you can see all the journey way up, and then finally the president of AOI in 2009-10, which was a feather on the cap and a very proud moment for all of us Delhiites. There is also a poster competition in his name. There's Anup Raj poster competition, and also the quiz which I will be hosting today. These are the few photographs. You can see Jyotiraditya Scindia. Yeah, this is he looks exactly like Madhavrao Scindia. So I was getting confused, but this has to be Jyotiraditya. And this is 2010 President AOI pictures when he was delivering the oration. This is the award and the great Santosh Kakkar and sir together for the poster competition. So it's such a eventful journey. We wish you all the best, sir. Such a beautiful family, and a little Vanya. Naira, sorry. Names are all like that. He's there, but such a wonderful girl. You can see she has synovial of the eyes in this comfortable house. We wish you all the best, sir, for the great life ahead, and may you keep on enlightening us again and again with your endeavors. Thank you so much. This was a small tribute from my side. Thank you.
Thank you, sir. With great privilege, I now invite Dr. Anup Raj, sir, to receive the Lifetime Achievement Award. I would like to invite Dr. Ishwar Singh, sir, Dr. H.C. Taneja, sir, and Dr. Ravi Meher, sir, to present the award. And Dr. Manish Munjal, sir, to present this award to sir.
The Association of Otolaryngologists of India Delhi State Chapter presents Lifetime Achievement Award to Dr. Mukhraj. This commemorative designation is presented to Dr. Mukhraj as Lifetime Achievement Award for his outstanding contribution in the field of otolaryngology, presented at 43rd Annual Conference held at Auditorium, Olympus Medical Systems India Private Limited, SAS Tower, Ground Floor Group. Thank you.
There was no this thing, and you were the only choice.
I would now like to invite Dr. Anup Raj, sir, to say a few words.
Thank you, Dr. Manish, for your generous introduction. We are honored by your own colleagues is a true testament to your lifetime of devotion to this work. And I am so honored to be chosen by Delhi OI. I'm really thankful. I've been in this field for over 50 years. I have seen lot devoted endless days to this work and accomplished a lot with all of you. And yet I see so much more potential ahead of us. It is a huge honor for me to be receiving this award today, because it signifies the value we bring as a profession to keeping humanity alive, to saving the countless lives. This is what motivates me every day. My services, my commitment to my profession shall continue, and I hope to continue to be mentor many more young minds of our country needs you. In the end, I would like to thank all the people that have walked into my life and made it better, as well as those who have chosen to disagree, to walk away, and made me stronger and even more committed to this work. Lastly, I would like to express my gratitude and blessings of my parents and the love of my wife, Dr. Archana, and my children who stood by me as we faced the storms that life throws at us, and always reminded me of why it is all worth it. I will always hold these memories close to my heart, and I urge you all to continue mentoring, teaching, and growing our profession. This is the best kind of legacy we can leave behind. Thank you very much.
Thank you, sir. We wish you all the best for your life ahead. I would now like to invite Dr. Ajal Gulati, sir, as the chief guest for Delhi AOICON 2021. Sir is Director Professor of ENT at Maulana Azad Medical College and also President Board of Ethics at National Medical Council. We welcome you, sir.
Thank you. Thank you so much. It's a pleasure being over here.
Sir, please continue, sir. We can hear you.
Yeah. Dr. Ishwar Singh, Dr. Ravi, Dr. Anup Raj, Dr. Taneja, Dr. Rajiv, the entire state of Delhi AOI. As I sit before you virtually from a distance of 7,900 kilometers, I'm in Netherlands at present, and just taking my flight back. It was delayed by 1 day, otherwise I would have been there with you physically. When Dr. Ishwar rang me up some time back, कि सर आप चीफ गेस्ट होना, मुझे अच्छा भी लगा, मुझे बुरा भी लगा। अच्छा इसलिए लगा कि मुझे इस लायक समझा, बुरा इसलिए लगा गेस्ट होता है किसी के दूसरे के घर पे जाना, लेकिन ENT, दिल्ली AOI, this is my house. So coming as a guest to my own house, मुझे कुछ हद तक बुरा लग रहा है. But then I think it's a part of the game, and what has been done today is something which our Honorable Prime Minister has always said, Atmanirbhar Bharat. Let us be self-dependent upon ourselves, and in this Atmanirbhar Bharat, what I see, the faculty which was invited, Dr. Devyani Lal, Sharad Chawla, Nishant Agarwal, Neeraj Mathur, Janki Ram, all of us are international heroes. The international faculty which is there are true hardcore, our own products and Indians. It feels nice to see them coming to this stage. We've had a difficult year last year and the year before that. We lost a lot many colleagues in this fight against COVID, but I guess every fight has its good points and bad points. We survived because there are survivors in this game. The times were trying and we were under tremendous pressure. The infrastructure was overwhelmed by the horrific second wave and the potential threat of the third wave. But yet, we have risen up to the occasion, each one of us. Why? Because the tenacity, dedication, the resilience, all these things helped us to reach today's time when we are safe. Because we are safe, the community also is safe. ENT took a forefront role in the COVID. Initially in the diagnosis, खांसी है तो COVID है, एनोस्मिया है तो COVID है, उसके बाद COVID खत्म हो गया तो फंगस आ गई, फंगस है तो ENT सर्जन है. So that's how things progressed and we reached where we are today. But I think among the worst sufferers for this COVID has been the medical education. If I look at it, the amount of loss our residents and students have had is phenomenal. You know, the other day, a group of residents had come to me, sir, kal lunch karne aana aap. मैंने कहा क्यों भाई? Sir, we are entering the OT for the first time. And remember, these residents had completed their 1.5 years of training after joining their MSENT. When you heard this statement कि sir कल हम ENT OT में पहली बार जा रहे हैं, it really hits you hard as to how much we have suffered in the past. But then I think with so many online seminars have been happening that we have tried to keep up with the education, keep up with the times every day. But you know, virtually one can be anywhere. But वो जो मजा एक हाथ मिलाने का है और गले मिलने का है and hug करने का है, that is something which we miss, and that is what we are missing in the surgery also. However hard we try, however good we show our surgical skills, however hard we try to teach surgical skills, but till you are on the operation table, till you are scrubbed, till you are gloved over there, you really cannot learn too much. I really dread the thought at the amount of training that we are undergoing at present in the MS courses. I dread the thought of creating a new degree of MD ENT because MS is master of surgery. Where is my mastery in surgery? Where is my surgery going? I do not know. The surgeons of this today, Janki Ram, I think probably has been morning to evening in the operation theaters teaching everybody. But then till you have the knife and scalpel in your hand and the suction beyond and the microscope in front of your eyes, really you cannot be a true surgeon. As the National Medical Commission came up, many thoughts went into where we can improve the whole situation. The curriculum revamping in ENT was one of the foremost of the features which the National Medical Commission has been into. And very soon you'll be seeing a radically changed outlook as far as the curriculum part is concerned. We are changing from the competency-based education, the competency-based education and evaluation today, from the past memorization of the facts which were existing in the past. Small group teachings, simulations, lack of large gatherings, lack of large conferences, all of us have gone through it. But this is where we are going to bring in the change. One important thing, which I think is a good news for all ENT surgeons, after doing MS ENT, it has opened a new era of opportunities for us. MCH plastic surgery, MCH head and neck surgery, MCH neurosurgery, all these areas have also been opened for MS ENT and will be notified very soon. So even after MS ENT, we were flirting around with the brain, we were flirting around with all the surrounding areas. So at least with MS ENT, we have more opportunities available for going into super specialization. We need to modify our approach. We modified that. Hybrid meetings have come across. Dr. Ishwar and Ravi have shown how well hybrid meetings can be organized. Teleconsultation is another area which has cropped up. And believe me, so many people have benefited by the teleconsultations that the National Medical Commission was forced to bring about the teleconsult guidelines and the regulations which are in force now, being gradually dynamically updated. It's a developing field in India. Earlier, it's not that we were not doing teleconsultation, but we were doing it in a haphazard manner. Now there are regulations for it. There are ways and means to guide how it is going upon. So I'll just wind up at this point of time by saying we have to face and achieve our goals by focusing on the goals and not the obstacles. We tend to focus on the obstacles like we did in the beginning of the COVID era, and now we are focusing on the goals as we come to the later phase or the ending part or the waning of the COVID era. I thank each one of the participants, each one of the members of the Delhi OI for letting me be over here and giving me this opportunity. Thank you, Dr. Ishwar. Thank you, Dr. Ravi, for letting me be over here from such a distance. Thank you so much. And I wish all the success to the conference.
Thank you, sir, for such delightful words. Lastly, I would like to invite Dr. Ravi Meher, sir, Director Professor of ENT at Maulana Azad Medical College and Honorary Secretary, Delhi OI, to deliver a vote of thanks.
Thank you, Dr. Deepika. Before I thank anybody, I want to thank Almighty God for giving me enough strength to carry out the work of organizing this conference after my father's demise just 2 weeks back. My sincere thanks to senior colleague, my friend, and my teacher and president of Delhi OI, Dr. Ishwar Singh. He has been a constant support to me throughout my career as secretary of Delhi OI, and he has helped me throughout my tenure. I thank Dr. Achal Gulati for being chief guest of the today's inauguration function, and I also congratulate Dr. Munraj for achieving the lifetime achievement. I thank Dr. Rajiv Kumar for his help as finance secretary during my tenure. Next, thanks are due to all my executive members of Delhi OI who have always stood with me and have given suggestions and criticism for the betterment of the association. My special thanks are due to Vipin Arora, who is a dear friend, for constant support, and he has always helped me in the time of need. I also want to thank the Olympus Medical Private Limited, who have provided this venue. This is a state-of-the-art venue for the conference, And my special thanks are due to Mr. Abhishek, Mr. Atif, and Mr. Jitendra for taking extra pain to make this conference a success. Their online support, food, hospitality was excellent, and I thank Olympus for this. Lastly, I want to thank my departmental colleagues, my head of the department, Dr. P.K. Rathore, my other departmental faculty for their constant support and encouragement. Special thanks are due to Dr. Vikram Wadhwa, who has helped me in organizing this conference, and also to my residents, my team of residents who have helped me constantly during organization of this conference. Thank you very much. Okay, so we will start with the scientific program now. The next session is Dr. V.P. Sood oration, and I invite Dr. Ishwar Singh, President of Delhi OI, to chair this session.
Good morning, everybody. So after the inauguration, we come back to our scientific program. And Dr. Janki, he needs no introduction. He is a well-known personality, or I'll say internationally, he is the face of ENT of India. Dr. Janki, as I say, is skull base, and skull base is Dr. Janki. Am I right, Dr. Janki? So just to complete the formality, Dr. Janki is skull base surgeon who is internationally recognized. His pioneer work is in the endoscopic management of juvenile angiofibroma. He has published a book on it. He has given a new classification. He has been invited as an operating faculty in more than 25 countries. Sir is expert in advanced skull lesions, and he has been international faculty in the skull-based conferences. So with this, I invite Dr. Janki to give his oration. Dr. Janki, stage is yours. Another thing, sir has been, Dr. Janki has acted in 2-3 movies. He is very dynamic, and he is a good dancer and a good singer. I saw him when I was in Kerala. He sings so well in Tamil.
Thank you for your nice words, Professor Ishwar Singh, sir. First of all, I thank the organizing committee for having invited me to present this prestigious oration after Professor V.P. Sood, sir. And before I start my oration, I would like to thank Professor Ravi Meher sir, for having invited me personally. In fact, I was supposed to come to Delhi for this same conference, but unfortunately due to COVID, we couldn't make it. But I'm very happy to see this hybrid workshop being conducted. I can see all the big stalwarts and giants of otolaryngology right on my screen. And it's a great honor to be talking to these wonderful personalities. To name a few, first of all, I was really thrilled to see Professor Alok Thakur's lecture, a talk on angiofibroma. Really, I learned a lot from this. Hats off to you, sir, for your brilliant work which you're doing and research which you're actually conducting in All India Institute of Medical Sciences. I then heard Professor Amit Kishore's lecture, wonderful lecture again, and really an eye-opener for so many out here on the latest about the implants. To mention some of my mentors, actually, I have to talk about Professor Achal Gulati sir. Achal Gulati sir has been my guide, mentor, friend, whatnot. In fact, he has actually sent one of my eyes, who is here with me, who works with me, Dr. Shilpi Bhatia Sharma. And I also congratulate Dr. Anup Raj sir for having got this Lifetime Achievement Award. Really a big applause for him. So Ishwar Singh sir, the president of Delhi AOI, really a big honorable position. I really congratulate you, sir, for doing this wonderful conference. And without much ado, let me start sharing my screen on this oration. The topic of today is invasive fungal sinusitis, and the oration is after Professor V.P. Sood, Dr. Vidya Prasad Sood. Am I audible, please? Am I audible?
Yes,
Hello?
Janki, audible.
Okay, right. So Professor V.P. Sood.
वो खिड़की खोल दो बड़ी आवाज से नहीं है यार ऐसी चलाई
Professor V.P. Sood, sir, is the founder member of All
इसकी
India.
ओरेशन के बाद होगा हमारा पैनल डिस्कशन
What is it?
Dr. Anil Moga has to switch his audio off.
Okay. Professor V.P. Sood is founder member of All India Rhinology Society, the single most important person to popularize rhinoplasty in India. He will always be remembered as father of Indian rhinoplasties. His rhinoplasty and endoscopic sinus surgery courses were extremely popular in India and abroad, and he conducted such courses for 38 years. His book on corrective rhinoplasty remained popular for all the ENT surgeons. He had been the president of Association of Otolaryngology of India, AOI, and All India Rhinology Society. So a person really doyen, a legend, after whom I'm privileged to give this oration. So let me start with my slideshow now. So the topic of today is surgical management, just the surgical management of mucormycosis in COVID-19. Let me be very honest. I have not yet completely documented and analyzed my data. We have done close to around 200 cases now, but we are still under the process of analyzing our data because every day, still we are operating on 2 to 3 cases every day now. So we find it difficult to analyze the data. Every day something new comes up in mucormycosis. So actually it was a big disaster to have COVID-19. And as we all know, we are one country which was actually affected, and we had several casualties. We lost a lot of colleagues. And we thought that by the end of the second wave, we will have a great relief. But then came up this dreaded disease, mucormycosis, which was again a disease which was confined mostly to this subcontinent. And I call it the unholy trinity. And India had an estimated 77 million people with diabetes mellitus. That is the second highest in the world next to China. And the total number of registered COVID-19, of course, we all know. And the prevalence of mucormycosis is 0.14 case per 1,000. In fact, we have crossed around 45,000. In fact, now we are getting more and more revisions. So it's actually devastating. It is 80 times more common than the other developed countries. Now, why is that we had mucormycosis? What is the pathophysiology? So patient presented with COVID-19, the second wave, particularly the Delta variant of the coronavirus. And of course, the treatment would have been corticosteroids. Most of them also took corticosteroids. Some of them actually had received less steroids, but then patient had pre-existing diabetes mellitus with steroid, increased it several times. Also, we know that the COVID-19 patients presented with increased ferritin level, and that along with the GRP78 and the COT-H actually caused a cascade of effects producing mucormycosis. So the probable causes would be the Delta virus induced immune dysfunction. It could be related to hyperglycemia. We have not done a lot of research on this, but we've seen patients, we are tabulating all the data. So much of data is there. In fact, I was actually invited to write a book, but I said, let me wait and study this disease before I really pen down my results. So diabetic ketoacidosis, some of them were actually non-diabetic as well. So we are actually perplexed about this mucormycosis. The role of ferritin and viral mimicry by hepcidin. So the viral angioinvasion. So we found a lot of thrombus inside the maxillary artery. We sent that separately for pathology, and we had fungus in it. So whether it is due to the virus causing thrombus, secondary fungus, or the fungus is causing thrombus and then the necrosis, we really don't know about that. But if the patient presents post-COVID with symptoms, which we all know, like, for example, numbness in the cheek or nasal discharge, anosmia, and then the palatal loosening of teeth, then we suspect mucormycosis in these patients. And then we order, so in our center, we have a tri-pronged attack. So we take a MRI, the first would be an MRI. And in that, again, 3 important images. We take a T2 stir, that is T2 fat suppressed, T1 with contrast, and of course, we always take a diffusion weighted image to look for the brain, to look for infarcts. Now, we don't stop with MRI in our center. What we do is we do an MDCT. An MDCT is very, very, very important, because nowadays, I'm going to show you what's the difference between the primary, that's the late case presentation, and the early case presentation, how the patients present right now versus how the patients presented before. It's a lot different. It's not the same. And we always do a cone beam CT. This is always a protocol for us to look for bone destruction and also the palate. So we are now trying to classify this. There are so many methods in which it's presenting. We really are a little confused. We're still tabulating the data. But my initial stage of this classification would be something like this. So I think it's previously what is talked about was the pterygopalatine fossa and the infratemporal fossa. We clearly found in these 200 cases that it's not so. So most of the cases, the pterygopalatine fossa, infratemporal fossa were completely normal. But what is the commonest site affected in our series was actually the maxillary sinus. So the maxilla, the osteometal complex, again, was affected. And from there, we could see that we can classify this into segments. So we're going to have something like a segmental classification. So we had either the OMC with the palate. Sometimes the OMC also was not affected, just the palate alone. So it's very sinister to find this. Actually, this mucormycosis, to classify this is going to be a big challenge in the future, but then we are trying hard to do it. So basically, we'll have this as the mother center, the osteometal complex, and from there, it goes into the palate. And from the palate, we see premaxilla also involved in some cases. So we're tabulating how many cases are involved, premaxilla is involved. So then it goes through the inferior orbital fissure, which is in the pterygopalatine fossa, into the orbit, of course. And then it can go, so something, these are all what is called the anterior spread, like the JNA, which I classified, the anterior spread and the posterior spread. The same thing we find in mucormycosis. There's no doubt about it. So we're finding an anterior spread and a posterior spread. So the anterior spread can be either into the orbit or with respect to the maxilla, I mean, maxillary sinus or the pterygopalatine fossa, infratemporal fossa. So you can see it's going to the premaxilla, it's going into the palate, it's going into the septum cribriform and the frontal sinus. So these are all the anterior spreads which we see. And then when we look at the posterior spread, I always classify it with respect to the carotid artery. Nowadays, we are seeing more and more carotid involvement. So we classify it into a midline and around the carotid and lateral to the carotid. So here, what we find is the clivus. The clivus is involved in a lot of cases. And we have now started addressing the clivus if the CT scan, the MDCT, and also the MRI shows problems. And then the clivus, the pterygopalatine fossa, the infratemporal fossa is one of the common sites of posterior spread. Of course, the median nerve, the V2 is also affected, and the V3 also, and of course, the greater wing of sphenoid. The greater wing of sphenoid has been found to be affected in many cases. And of course, the inferior orbital fissure, superior orbital fissure, the cavernous sinus, the Meckel's cave. So the Meckel's cave, and in fact, we have found sometimes lateral to the Meckel's cave going towards the temporal fossa, and also it's involving like this, it's creeping like this, it's creeping osteomyelitis going along the greater, from the median, from the foramen of rotundum, it goes along the greater wing of sphenoid, sometimes involving the bone here. Along the, even the zygoma has been affected in some cases, the temporal fossa, the zygoma, the lateral orbital wall. So the lateral orbital wall has been affected in many cases. So again, piling up data. Now, we are also seeing one whole batch of revision cases. Even now, we are doing a lot of revisions. And in that, we find more of posterior involvement. So surprising to see in revisions, we have a lot of posterior involvement. In fact, so many bilateral involvements we have seen. And greater wing of sphenoid, clivus, apex, that is the orbital apex, Meckel's cave, and V3. These, I think this is one of the commonest sites in a revision case we have seen. And of course, the frontal bone. Why is the frontal bone involved? I really can't understand this disease at all. The cribriform plate, and then the frontal retroorbital. So for the, we give retroorbital amphotericin in cases of involvement of the orbital apex. But if the orbit is left, so there are some cases where we leave behind the orbit, and these patients present with frontal involvement, frontal lobe involvement. But the abscess, intracranial abscess, we find that if the greater wing of sphenoid is involved, there's a lot of chances for the temporal lobe abscess. And if the cribriform plate is involved, there's a lot of chance for a frontal lobe abscess. Of course, we have found frontoparietal abscesses, and we have found also cases of occipital lobe abscess. We are not able to explain, but I think it's all blood spread. So, so this is how we have found. So this is just an example of how we look at the revision cases. This is actually the this is the T1 with contrast. You can see here very clearly the hypointensity. Look for hypointensity in these scans. Hello.
You are audible.
Yeah, am I audible because the current has gone off in our place? Hello. The current.
Yes, audible.
You're audible.
Yes, we can hear you. Yes.
The current is gone, so I hope it will come back. Okay, now, so you can see here that this is actually the T2 coronal. And if you look at this very clearly, you can see that the fungus is hypointense. So in most of the scans which we think about, the T1 with contrast and the a fat suppressed T2, you find that we are going to have a detailed analysis of the scans, and also they'll be coming out in a very nice textbook which we are going to plan. Okay, so this is how we always do a cone beam CT for all our cases. So every case a cone beam CT is done to look for the palate, what segment of the palate is to be removed. We generally avoid total maxillectomies at all. In fact, I hardly remember a case where we have done a total maxillectomy. we've done everything endoscopic. So everything endoscopic and segmental resections have been done. And of course, we have had very, very good results. Now, we have had cases where we had to do, we had seen patients who have undergone bilateral palate removal, a total complete. So these patients have a problem with nutrition, taking food, and also phonation. So we try to give them prosthesis from the zygoma, and that is generally done. All reconstructions are done only after 3 months. We don't want to reconstruct any case before the healing has taken place. Now, we've also seen more than around 20 cases of intracranial abscesses, and we've seen temporal lobe abscess, we've seen parietal, also frontal lobe abscess and occipital lobe abscess. All the lobes have been affected, but the commonest would be the temporal lobe and the frontal lobe abscess, which we have seen. Okay, now let us go on to case scenarios. The commonest being the sino, that is osteometal complex, also the palate. So this is one such case. So you can see here that this is actually the T2 fat suppressed. You can see that the palate is involved. But in an MRI, we are not able to properly locate how the palate is involved. This is something which is actually a problem. We actually see that the palate is involved, but then we are not exactly able to locate. So of course, MRI can detect bone. There's no doubt about bone involvement. But then to me, I think the better would be cone beam CT. And you can see how beautifully and segments, you can study the segment of the palate which is involved. So I honestly appeal to all treating mucormycosis to include cone beam CT in their protocol for evaluation of the palate so that we can avoid total palatectomies. So what we do is we just remove segments of the palate, a little bit of the septum also sometimes in some cases, and we actually preserve the mucoperiosteum. So, and then a beautiful implant is given. We have started implanting them. Now that we have patients who have crossed 3 months, and we have started implanting them. So basically, when you look at these patients, maybe after maybe 3 weeks or 4 weeks, this is how it looks, the healing. We are also studying the healing process. And in fact, if you have polypoidal changes like this, then it's good healing. This is what we have found. There's a little crusting always initially because there is raw bone, but later it beautifully granulates. So let us see some cases. You see here, you see, I told you the MRI can definitely detect the bone involvement. This is greater wing or sphenoid involvement. So you can see the clivus also is involved. Let us see how, and you can see this is the sag, and also you can see the clivus and the sphenoid involved. Let us start seeing some videos. So I'm just going to show you only the parts which are involved and how I operated on such patients. So always like a pituitary surgery, we go in for a posterior septectomy. And in this case, I generally don't do a Denker's. Suppose the maxilla is not involved, perfectly normal, the osteometal complex, just the posterior disease. Then we just go in and do a medial maxillectomy in such cases because we have to address the greater wing of sphenoid because both the greater wing of sphenoids are involved. So here is the owl's eye appearance. As you see here, the anterior face of the sphenoid sinus. And then we start drilling. It's always four-handed. Dr. Shilpi Bhatia Sharma shows me the views, beautiful views she gives, totally irreplaceable in our center. And honestly, when I look at sometimes some cases, anteriorly, all the bone appears normal. In fact, when you look at the anterior part of the bone, we get carried away thinking, should we actually operate on this patient? And then what happens, once you read the scan and the MRI and also the MDCTs properly, then you can see that the posterior part is completely involved. You see, anteriorly, if you look at the bone, it was normal. But as we go posteriorly, you see what happens. I'm now drilling off the clivus. There's no anatomy at all. I'm trying to create anatomy. That's actually the cellar floor I'm trying to create. So in some cases, the carotid is also involved. You see now the pus is coming out from the marrow. You see that? Actually, what happens is that this marrow should contain blood. It actually bleeds. There is no bleeding at all. And that all that is filled with fungus. We send that material and it's all full of debris. And that debris, my pathologist reports that there is fungal elements inside that debris. So you can see that's a greater wing or sphenoid being drilled by me here. So see, anteriorly, everything looked normal. This is why I think we are facing revisions, because actually what happens is the surgeons, when they see the anterior part, it looks beautiful. It looks fantastic. But as we drill, we see all that pus. We have that bone which is completely involved. And now I'm going in for the infratemporal fossa, the pterygopalatine fossa through the medial maxilla. You see that. The V2 is a nerve which is constantly, or maybe a lot of patients have involvement of the V2 in this disease. And that V2 is a very important landmark for me, especially in, you see the V2 above. I'm drilling below the V2 and going towards the base of the temporal lobe. And I have the median and the V2 as a landmark, and I keep drilling till I get a normal bone. So what happens is that the outer cortical bone is intact, and then the inner cortical bone is intact. But in between, the marrow spaces are gone, and they are filled with fungus and pus and debris, and that's why the patient has severe pain. So it's sometimes the outer cortex is completely gone. It looks yellow. I will show you some other. So there are varied presentations of this mucormycosis. So if you find that the dead osteocytes, so you can see that's a V3. That's a V3. I've gone lateral to the V3. Always remember that when you deal with a V3, ask your anesthetist to look for bradycardia, because we also published that you can have severe cardiac arrest or asystole during your procedure. So this is actually the drilling of the greater wing or sphenoid. Sometimes I've gone right laterally. So that's a carotid canal. The median, that's a V3, lateral to the V3, the floor of the temporal lobe. In this patient, the patient did not have a temporal lobe abscess. So we are now trying to pack that and then going to the right side. So in some cases, what we have done is, not some, nowadays we are doing a lot more cases of bilateral greater wing or sphenoid involvement, having the median and the V2 as the landmark. And you can see that we drill till we get normal cortical, inner cortical bone. So once we do that, but there are some patients, as I told you, the whole bone is gone, outer cortex, the inner cortex, everything, till the dura is completely gone. And that is very simple. You can definitely make sure that it is fungus. You can make it by your eye, but these cases are a little deceptive. So here we are drilling out, and I will see that every bit of this marrow space is completely open up, and then you give amphotericin washes. So you give amphotericin washes, and then what happens, you see here, once you drill that, and then this is how it looks. So this is what we're going to present now. Of course, not yet published, sent it for publication. It's called the Holy Cross sign. We're finding it in many cases of our revision mucormycosis. Bilateral greater wing or sphenoid, right from the planum till the level of the palate. Now, approach to revision skull base, this is what is going to be the real challenge which we are going to face in the future. I'm sure we've seen around 45,000 cases of mucormycosis. I don't know how many patients are alive. I'm not sure about the data of the number of deaths. In our center, we have had 4 mortalities. Out of 200, 4 people have died. Of course, various causes. You see this patient actually having a complete frontal lobe, a temporal frontal bone, the temporal bone, the parietal bone, all involved. Of course, this mesh, we have just planned it. We will not do it right now. We'll do it after 3 months. Just see this video. So I've done the nose part of it, and I'm just going to open up the pericranium. I'll be using it as a flap. And once I use it as a flap, this is being done nowadays very commonly in our center. You can see that many bones of the skull are like islands there involved, and they become completely, see that. This is a very clear case, outer cortical bone involved. So you know exactly the bone is involved or not. And then we completely remove that bone, something like a FTOZ, but you see here how vast this it's actually a dreaded disease. I'm telling you, even the COVID can be tolerated, but mucormycosis, believe me, is such a devastating disease. And I don't know how the patient's mental conditions are. They become a little psychotic. You know, imagine removing all this in a very nice gentleman who is actually a bank executive. You see that? It's all fungus, full of fungus. And the mucus sitting right in the bone and also in the dura. You see here, right on the dura, and then we start scraping off all that dura. Of course, let me tell you that fungal invasive disease is a teamwork. So we work along with the FACS-MACs, the neurosurgeons, and of course the ophthalmologists. But the primary is the skull-based surgeon. So we need not an ENT surgeon, but a person who is completely trained in skull-based surgery, because this is pure skull-based surgery. You know, you should know how to reconstruct this. If you have a defect in the cribriform plate, then you should know how to reconstruct all that. So that needs a proper training in skull-based surgery. Now, I'm removing all that bone from above the orbit, and that's actually the frontal bone coming out. You can see that this is the nasal process of the frontal bone. See that completely involved, and then you can see both sides, the frontal lobe, the gyrus rectus exposed, and the roof of the orbit being removed now. And once I remove it, you can see inside the nasal cavity, and you can see that this is such a big hole which is produced. I've now cleared all that dura, and then I'm removing that fungus from the orbit, the superior part of the orbit, going laterally here. The superior wall of the orbit and lateral part of the superior wall is also involved. See the devastating disease. Now, then you wash it with dilute amphotericin. Of course, I just want to tell you that surgery is just one aspect, and then followed by medical treatment. I don't think that the medical treatment is going to cure the patient. I've seen patients receiving at least now 300 vials of amphotericin without removing the bone. This patient actually was a revision, 6th revision or something like that. He had received some 300 vials of amphotericin. That's not the right thing to do. So even if you give him 1.5 tons of amphotericin, he's not going to be all right unless you clear all this osteomyelitic bone. So we did a temporalis a muscle rotation flap, and then finally, because we had to cure, this patient is around, same patient, around 1.5 months post-op. He's happy, and now he wants reconstruction after 3 months. So I'm going to proceed on to my 2 more videos which I wanted to show you. So I'm going to show you 2 videos, very, very interesting cases. This is actually the, I hope you're able to see my screen now. Okay, so here we are. You can see that this is actually the fungus involving the cribriform plate going into the frontal lobe. See the front, and believe me, don't take a T2 fat suppressed or a T2 image for looking for an abscess. So that gives you a false sense of orientation, because even a gliotic brain can actually mimic it. So take a T1 with contrast. You have a beautiful ring enhancement, and what I'm going to show you is actually dissection of the cribriform plate. You see how I do the anterior craniofacial dissection. You can see that I'm now using the coblation to coblate the anterior femoral artery. And once I do that, I'm now trying to get all the dura which was diseased completely out. And I'm now drilling off the crista galli. So now we have seen isolated crista galli involvement, which is actually seen beautifully in MDCT in some patients, and we have got videos of removal of just the crista galli. You see the left gyrus rectus was normal, and then now we are opening up the right side. You see the granulations which are sitting right over the basifrontal region, and you will have to go ahead and do this removal of the frontal lobe abscess. Now, in our series of 20 cases, 3 cases actually recurred in the temporal lobe, and we had to make our neurosurgeons do a burr hole craniotomy for these cases. So 3 out of 20, that means 15% of our cases actually recurred after doing this. But this is slightly more conservative, because anyways, we have to do a nasal procedure for removing the fungus from the cribriform plate. So of course, the neurosurgeons can't do that. So we can actually go inside, go ahead and remove this abscess like this. But this is a little conservative. And then, but none of our frontal lobe abscess have recurred. Only the temporal lobe abscess, I think, needs complete thorough removal of the walls of the abscess, which actually forms after 1 month. In fact, I removed all the walls, but then still they had recurrence, the 3 people. Now, what we do is we'll have to reconstruct. Of course, we'll have to create a Marcos window and reconstruct it with a pericranial flap. Of course, I'm now keeping an inlay facial ada, and of course a non-lay facial area followed by a pericranium and then putting in a glue. Now, how does this post-op look? Of course, no time for all that. Let us see this a combined approach. So we have also performed a lot of combined approach. That's a draft 3. And once you do a draft 3, you see this patient had a high involvement of the posterior table of the frontal sinus. You see how high. You can't approach it through a draft 3. So we did a mini Lynch Hobart, and then we are trying to open up, and you see what's happening here. This is completely osteomyelitic, and you can see the fungus there, and I'm trying to clear that. Now, this is above the roof of the orbit. This is all osteomyelitic bone, and you're seeing that I'm clearing the roof of the orbit, and we are now going far laterally, and I'm trying to remove that bone with a Manhattan gouge. Of course, I can't use a drill because the fat will actually go into the burr, and we are now going deep there. I'm using my suction to protect the periorbita and removing all that bone. So we have to go till the temporalis muscle. You see that that's the temporalis muscle is completely exposed there. And when I press from outside, you can actually see the movements inside. That's actually the final result of this patient. You can see that this is the Denkers with a combined approach done. Now, this is the post-op of the same patient. You can see that the post-op looks very good. The patient is doing very fine with a good dose of amphotericin. My last case I want to show you is again a revision mucor involving the frontal and the cribriform plate. You can see here that what I'm trying to do now is we use what's called the Rubina camera of Karl Storz, and that Rubina camera gives us, that's the IGS system. So we inject indocyanine, and once we inject indocyanine, then you will see the dead bone, and you can differentiate dead bone from good bone. So you can see here that that's actually the IMAX being ligated. And once I ligate the IMAX, now you can see that's all the dead debris. And I'm going to show you how a Rubina camera is useful. It's also useful for showing the vascularity of the bone. See how much of osteomyelitic bone is here. And I'm now trying to remove that. Now let us see whether that's actually the median nerve coming into the picture. That's the floor of the temporal lobe, which is being curated out. And now you can see the greenish hue of the clivus. I'm using a Doppler to check the carotid, drilling off the clivus completely till the level of the inner dura. And now I was a little, that's a cribriform plate. That's a cribriform plate being removed there. And you can see that that is actually the cribriform completely gone. The crista galli was involved. You can see here that the frontal bone was also diseased. I think I've forwarded that, the Rubina part of it. It's okay. That's a crista galli being removed. That's a crista galli, and that's completely osteomyelitic again. You can't leave this and put the patients on amphotericin or posaconazole or isavuconazole. There's no point in doing that because the patient is going to come back with, see the V3 here, that's the carotid here. You can see the Meckel's cave. Both the anterior cranial fossa and the middle cranial fossa was completely exposed in this case. So this is the kind of cases which we are finding for revisions. We use a temporoparietal flap for this and a pericranial flap for this. So that's a kind of reconstruction we did if you have a CSF leak. So thank you very much for giving me this opportunity to present our small experience. Of course, just 200 cases is not a big number, but then we're doing a lot more of research and trying to publish this and also bring out a book. Really thank the organizers of Delhi AOI, fantastic team, and thank you during this COVID period on a Sunday, and doing a workshop like this is really a conference like this is really commendable. Thank you one and all. Thank you.
Thank you, Dr. Janki, for such a lucid and wonderful presentation. We had an epidemic of mucormycosis after COVID, and you dealt the pathophysiology investigations, MRI, and you told the utility of cone beam CT scan that we are not utilized in Delhi. I think none of us have used. I am not aware if anybody has this. You showed so many cases and intracranial actions, and I think you are more of a neurosurgeon rather than skull base. I can say you are a neurosurgeon. With that, you had shown the wonderful cases, and it was such a good presentation. I thank you so much. And with this, we present you. Had you been here, we would have felicitated you with the medal and certificate. But we are going to send you this certificate by post. And thank you for such a wonderful work which you are doing. And please continue to do. And thank you so much.
Dr. Ishwar Singh, I just want to tell only one thing. During this COVID period, we have been meeting virtually, but honestly, I feel gale lagane se upar kuch nahi hai. Nothing like holding and hugging each other. And I'm just dying to meet you all, you know. I'm tired of virtual.
Have made us more this thing. There is no blood loss, there is hardly any bleeding, and this is like a termite in the skull base. You are more confident in removing the bone. It comes with a little effort, or it's very fragile. So I think this mucor has given confidence to the endoscopic surgeon. Am I right?
Absolutely, absolutely.
So we'll have you next time. We'll host you once more when we have in future. Thank you, Dr. Janki, for your nice presentation.
Thank you for this opportunity.
So thank you, Dr. Chanki, for that wonderful presentation. We now proceed to the next session, and this is a panel discussion which will be moderated by Dr. Rakesh Kumar, and I invite Dr. Kavita Goyal and Dr. Anil Sapaya to chair this session. Dr. Kavita Goyal, is she online?
Yeah.
Yeah, she's there, and my colleague will be finishing off with her remarks regarding the whole panel. And I'm just trying to get out of the mesmerization that Dr. Janaki has spread all around. So I think Dr. Rakesh will give a very good challenge to the excellent presentation we just saw. And we have a fabulous moderator and an equally fantastic panel and a good topic. So without wasting any time, Dr. Rakesh, please come forward and introduce the panel and your topic.
Hello. Dr. Sapaya.
Yeah.
Am I audible?
Yes, yes.
Very much, very much.
Okay, thank you. Thank you for the kind words. And it was wonderful to hear Dr. Janki as usual. And suddenly, like from flying in the sky, and I will bring you down to the earth again. Okay, so share. It says that other participant is sharing the screen, so I cannot share my screen.
Oh, I think I will. Yeah, that's true. Is that okay?
Yes.
Yeah. I think Kavita, you'll also have to
so I
off
think
your video.
It should be okay.
Of my video?
Yeah.
No, it's okay. I think
okay,
now
it's okay.
I can share it.
Go ahead.
Yeah. So the topic is revisiting the Muscat surgical stomach disease, and this is what we had yesterday. All Delhi after 3 hours rain, it was all everywhere water. So it was something like once you left the right hand to do mastoid, nowadays the emphasis in otology is more on the cochlear implant. So mastoid surgery, you leave right hand there, and probably his feeling is same, like thinking where to go, where is the manhole, where is the complication, where is the trap. So I thought, I was discussing with Dr. Ravi, and he was of the opinion that we should do something specifically to the junior agent and the young ENT colleagues, so that the practical part, if we can discuss. So the purpose is to revisit the mastoid surgery. So we have the excellent the stalwarts in the field of otology, starting with Dr. J.C. Pasi. He was Dean and MS of Monash Medical College. And we all know his work in otology, mastoid surgery, combined approach, mastoidectomy. Dr. Ishwar Singh, again a stalwart. He does so many things, including otology. Dr. A.K. Monga from Gangarang Hospital. He is one person who will only say or discuss things what he does. So we need those comments, what everyone does, instead of the theory or what one should do, what we are actually doing and how one can help the resident and the young ENT surgeon. Dr. Sanjeev Kathuria, again, very experienced otologist. Dr. G.B. Singh from Lady Harding, we all know him. Dr. Salabh Sharma, although he has been better known as an cochlear implant surgeon, but we all know that when he started, he was into endoscopic sinus surgery and otology, obviously his hold. Dr. Nilima Gupta from GTB Hospital, again a very experienced ENT surgeon, and Dr. Prem Sagar from AIMS. And we have a young ENT surgeon from MMC, Dr. Vikram. I've heard that he does a lot of endoscopic ear surgery. So we will gain from his experience. So what we will start is that when we see a case of squamous type of the chronic otitis media, what are the investigation and what is the logic one should apply before we order the relevant investigation? So I'll start with Dr. Vikram, please. Hello. Hello. Dr. Vikram, has he joined? I'm not getting any audio or video of Dr. Vikram. So Dr. Prem Sagar, please.
Good afternoon, sir.
Oh, good afternoon. Welcome.
Thank you, sir. So the investigations, the first investigations that I would include is a pure tone audiometry, following a baseline clinical evaluation, which is microscopy or autoendoscopy, and tuning fork test and other examinations. The investigation first in line will be an audiometry to find out the degree of hearing loss, the degree, the site, and the type of hearing loss. Then radiology in the form of, in today's era, we are considering going for a CT scan rather than an X-ray. And if it's a complicated case, then of course a ear swab of the discharge to find out the organism and the sensitivity of the organisms. And if the patient has complaints of nose or suggestive of some sinus disease, then we may go ahead with endoscopic evaluation of the nose. And if required, then of course radiology to find out the sinus and nose pathologies, because we have to address that first prior to addressing the ear surgery in elective cases. And MRI, of course, if we think of any intracranial complications of mastoiditis or CSM.
So very good. So any other panelists want to add something?
Yes, Dr. Rakesh, am I audible?
Yes, sir. Yes, sir. Perfectly.
Yes, Prem has already listed all the investigations, and I'm happy that she has omitted the plain X-ray lateral oblique view of the mastoid, which I also don't like to do unless it is a fresher who is attempting surgical procedure to find out the surgical landmarks, which is and the pneumatization pattern of the mastoid segment of the temporal bone, which is the only logic to, according to me, for asking for a plain X-ray these days. We should try to get the HRCT temporal bone in all surgical cases.
Okay. Any other panelists? Their experience if they want to add? Dr. GP Singh?
I think I'm okay, sir. I believe that HRCT scan and the endoscopic examination, along with pure tone audiogram, they form a basis for that. But then, one has to understand that a CT scan is not being done to diagnose the cholesteatoma disease. It is being done to aid your surgical technique, to plan your surgery and to prevent the complications. All postgraduate students have to understand that microscopic examination of the ear, especially the endoscopic examination, which will highlight the cholesteatoma and all, along with your pure tone audiogram, which gives you the hearing status. A CT scan tells you the extent of the disease. And of course, you can plan your surgery by seeing a CT scan. A CT scan per se does not diagnose a cholesteatoma ear disease. That has to be always kept at the back of the mind.
Okay. So everything has been covered, and CT scan, beside giving you the cholesteatoma and the anatomical detail, also it gives rise to any complication like which may be missed on the X-rays. Anyone regarding speech audiometry? So when, if it is needed, and if yes, when? Hello. Yes, sir. Dr. Kachuria, yes.
Speech audiometry is important, but only when the your pure tone audiogram does not matches with your clinical assessment. And secondly, in a revision surgery, CT scan is a must. It is absolutely important to have the CT scan, HRCT, particularly in a revision surgery. And if you can get hold of the previous surgery notes somehow, this becomes an important point.
Dr. Rakesh, speech audiometry is not really done. It is pure tone which gives you the fair idea along with your tunico. Speech audiometry is time consuming, plus it can be done if there is associated sensorineural hearing loss, and speech audiometry for exam point of view, that is more closer to the normal speech which is used for communication as compared to the pure tone. That is the advantage. As per the CT, the earlier speaker said, CT is required for any congenital this thing anomaly, or there is a complication, or there is a revision surgery. In that, the CT is a must, so that you can know what all has been exposed or what is left behind, or whether the dura or the sinus plate has been eroded. That is not routinely seen. And rightly, the speaker said, if the previous notes are available, that will give you a good clue. But sometimes the finding, this thing, surgical finding and the notes, they don't match.
Yeah, correct. So the speech audiometry is not a routine test done, only in specific situation one can ask for this. And regarding radiology, plain X-ray nowadays, before it was like CT scan may not be available everywhere and maybe cost involved. Nowadays, it's very affordable and available everywhere. So the CT is now becoming more and more standard of care. In that one get HRCT, but only one concern for the small children, that the exposure of the radiation, so that much more than the plain X-rays. And especially areas where still in an area where the money is the important aspect, and the poverty, probably X-rays are not that totally gone test. So, but now the standard of care is HRCT.
Dr. Rakesh, can I add one thing here?
Yes,
about
sir. Yes, sir.
HRCT temporal bone is
perfect.
also,
Yes, sir.
it is also important from medical legal point of view.
Yeah.
We have faced a case in the High Court where it was, alleged that why, when the facility is available, why have you not gone for it? Someone got intraoperative complication, which was not detected on plain X-ray, and HRCT was not done, and there was no answer to the query in the court. So from that point of view also, we should try to get HRCT at least in all surgical cases, whether it is revision case, uncomplicated or complicated case.
Yes, sir. So, Dr. G.B. Singh, so beside whatever the examination microscope and all, are you using those scales which are available stores like the middle ear risk index,
No.
misery score, oops score yesterday it was being
No. I'm very sorry that because in our institution, I think Mary score we are using sometimes for academic interest in tympanoplasty.
Yeah.
But not for mastoid surgery. And we don't use misery score at all. It's not a routine protocol, and we have done no thesis on this, and it is not routinely done. But yes, we did Mary score in few cases of tympanoplasty, just for the sake of like academic interest. But to be honest, we are not using Mary score and misery score in our institution.
Any other panelists want to?
Yes, Dr. Rakesh.
Yes,
my last PG last year completed thesis on tympanoplasty only, like GB Singh said, not on the mastoid surgery. We did use on 50 odd cases Mary score, but it's not a routine thing in the pre-operative assessment and preparation for surgery.
Dr. Rakesh.
Yes, sir.
The aim of the mastoid surgery is eradicate the disease. Second is to have a serviceable hearing and give a dry air. If you go by those aims, so these all criteria are covered up, whether cholestoma is removed or the discharge is not there or wetting. So this is more of academic interest, or if you have a performa or doing thesis, then it's okay. But if you have a protocol, then these all can be utilized. But generally, these are more of academic thing, which though it can be utilized if a patient can be given and he can be told objectively, okay, this is a thing, you have score, lesser the score, better the outcome. So that is the thing, but I don't think it is routinely used unless in an academic thing or in a thesis or a paper research work, these are used, but not in follow-up in routine thing.
Okay. Any other comment regarding this?
Good afternoon, Dr. Rakesh, sir.
Yeah, Dr. Nilima. Yes, sir.
Yeah,
Yes,
sir, we are also not using it as a routine or as a screening and per operative findings. And but if we keep these things in mind, maybe when we are prognosticating the patient and if we prepare a proper protocol, then I think this score can help us in the pre-operative counseling and also teaching purposes to the residents.
So I was just going through this preparation of the question, and I was just thinking, the otology beside cochlear implant, all of a sudden it has become more of a like the things which less and less people want to do it. probably in this age of technological advances and the try to make things as objective or as documentable as possible, probably that is not a bad idea to use scores which are not that time consuming as well. And sometimes because patient comes like with ear discharge, pain and impaired hearing, and post-op also suppose when we say we do mastoid surgery, we don't guarantee that 100% ear will be dry. So patient has ear discharge before, ear discharge afterward. So at time it is easy to explain them or the counsel them if you use them. So it will not take more time. It is just a few minutes more, and probably it can guide us to counsel or to convince patient about the condition of their ear, the post-op outcome. So this is what I was thinking. So, but yes, as almost all panelists were saying, not using it, we have also.
Rakesh, this can be used in a otology clinic. So in a routine OPD, I think it's difficult, but if you have special clinic like analogy, otology, where this can be used, and you have only otology patients, then it can be of utility and patient can be given up.
Operative cases, yes. Yes, you are right. So we are also not using it routinely, but as Dr. Pasi, Dr. GB Singh mentioned that for thesis research, yes. So the next is Dr. Shalom. So what are the preoperative point you consider when you are talking to your patient, when you are counseling your patient? What all things are coming into your mind? Because usually when we are teaching the PG or the trainee, they are not able to read into our mind what is going inside. They only see what you are saying.
So if I have a patient and I'm met them for the first time, I've seen the investigations, and if it's a primary case to be operated for the first time, then I would tell them that the primary aim of my surgery would be to remove the disease and to give a good dry ear, safe ear, so that they don't have any complications later. And then also as a secondary to that, I would try to improve their hearing. The problem is, of course, some of the cases they are cholesteatoma hearers, or they have a draped, tympanic membrane on the stapes, so they don't have much of a hearing loss. So if you have a patient with a SAC and a cholesteatoma, but a hearing of only AB gap of only 15 decibel or 20 decibel, then it's not. They would be expecting after surgery to get an improvement, and you have to counsel them that no, it's possible that the hearing may in fact drop a little bit, especially if the ossiculoplasty or the cartilage osteoplasty is not so effective. And I usually tell them also that in about 8 of my 10 patients, I'm able to get good usable hearing within about 15 dB gap. But in 2 out of 10 of my patients, I'm not able to do that in spite of the best efforts. And then in those cases, a secondary surgery or revision surgery may be required. Also, that I really don't tell my patients that they may be a revision for cholesteatoma or squamous disease per se, because usually I am able to get most of my patients. I think they don't really get recurrences, or residual disease is not a problem I've seen. Maybe I've had a good, great teacher also, Dr. Lahiri. So, but using all of that, and also, I think one of the biggest problems why we get these we don't get a dry ear at the end of surgery is because the cavities are large. So we have to do something obviously to obliterate that. I tell the patients that I will be doing that also, and that it takes about a month.
We will come to that.
Yeah, that's it. Yeah.
Yeah, correct. So, any other panelists want to add to that?
Dr. Rakesh,
Yes,
I am in line with Dr. Shalab, but for the about the hearing gain post-operatively, I will. It will depend on the permeatal findings, the findings on pure tone audiometry, tuning fork tests. Depending upon the amount and type of hearing loss, I will, during counseling, tell the patient about the hearing gain. This will depend entirely on the pre-operative findings and the investigation reports. But I will not say to most of my patients that hearing can go down post-operatively. I don't want to lose the patient. Shalabh should also not lose. He is in a private practice.
Yeah.
So,
No, but it's for those patients
Yeah.
who have very good hearing in spite of the disease. So there it can be a problem, and I don't want any patient to come later and tell me that you told me there'll be an improvement and it's got worse. So because if you have a 15 dB AB gap and it drops to 25 after surgery, then the patient is not going to be happy. And
yeah, that can happen once a while, but this is the time when we can always be positive and try to give a better hearing, and patients do get better hearing post-operatively. We have all the means and the gadgets available these days. So I personally feel that hearing gain, of course, every patient wants a hearing gain. Even if the patient is not aware of a continuous discharge post-operatively, they all think that it will be a dry ear and a better hearing ear post-operatively. So we should focus, quite a bit on post-operative hearing gains.
Yeah, Dr. Pasi, right. For the postgraduates and young ENT surgeon, there's a very good point which has come out of this discussion, that any patient who has near normal or normal hearing in the ear with cholesteatoma, one should be very, very careful when you're counseling the patient, because post-op, if hearing comes down, then they will be blaming you. So these patients, it is a good precaution and advice that you counsel them that after surgery, at times, because the cholesteatoma may be bridging the gap, or the cholesteatoma is going behind the ossicles, and during the course of removal of cholesteatoma, and in spite of reconstruction of the ossicular chain, the hearing may be less as compared to what they have at the moment. So that's a very important precaution, especially with the patient who have hearing which is not decreased. For decreased hearing, yes, always one has to be optimistic and has to give the positive outcome. Yeah. So, yeah.
So certain other points which I take care of during the pre-operative evaluation or planning or counseling are like the status of the other ear, the hearing status, and the surgery or disease factor of the other ear, the symptoms of the patient with which the patient has come to me. Suppose patient has not come to me with any complaint of discharge, hearing loss, giddiness, only heaviness, then I have to explain the patient about the post-operative symptoms which the patient may experience transiently or permanently. Then another factor will be the age of the patient. So like pediatric patients, the planning will be different, and the elderly patients, we may or may not go for surgery if they're not fit for surgery, and depending upon the disease extent also. So these are few other factors which will be affecting my preoperative counseling and planning of surgery.
Dr. Rakesh, I can come in?
Yeah,
Hello?
definitely.
Dr. Rakesh?
Dr. Vikram. Welcome.
Sorry, I was not audible earlier.
No, it's okay, no problem. Yeah.
Yeah. Just two, 3 points I just wanted to add in counseling. One thing is that mastoid surgery is not the only thing. Follow-ups are very, very important. And taking care of the cavity post-op for a period of time, say about 1 or 2 months, 4 to 6 weeks, essentially is very important. And a little bit talk about complications should be there with the patient, because your residents are there and they will be operating, and probably they might have a chance of a facial paralysis or paralysis. So there should be a little bit of talk about complications with the patient. There are chances, there are 1 or 2% chances of facial paralysis also. So a little bit of counseling regarding that and should be done, I suppose.
Yeah, right. So it is. It is not only residents who can create complications with mastoid surgery. Is every time you go for mastoid surgery, you find something new. So the complication can happen in any hand, even experienced surgeon. So one should always counsel them regarding complication.
When in private practice, at least when the patients come and ask me about complications, and they almost always do, and they ask especially about facial palsy,
Definitely.
then I always tell them that facial paralysis is a possibility in any ear surgery, especially in a mastoid surgery. It can happen even in my hands, but I just tell them it hasn't happened yet in so many years. Hopefully, it will never happen in the future, but it may. And if it happens, then there must be, because I could not do anything about it. So this is exactly what I tell them.
Yeah, so this is important, not telling the theory. See, what is the chances of complication in surgeon's hand, who is counseling, who is going to do surgery. So that is important. Yeah. So any other panelists want to add any point regarding counseling and the pre-operative?
Sir, I would like to add that
Yeah,
if we are
Dr.
counseling for the proper follow-up, we can also tell that it may be possible that per-operatively we reconstruct the ear and the ear becomes dry, and we may have to do a second look surgery for the hearing reconstruction. So we can tell them about second surgery in case the findings per-operatively are so.
Yeah, right. So most of the points have been discussed regarding age of the patient, the education level, profession, what he does, especially person who is into music and the person who is executive. He need both hearing. So one has to counsel accordingly. Condition of the other ear, if it is the only hearing ear, again you have to be careful. Then accessibility to the healthcare facility. The person who is staying far away from the healthcare facility, you have to be counsel them little differently regarding the type of surgery and what your aim is, and then motivation, that is important. And as all panelists told, the clearance of disease is the first and the foremost aim. Second, the dry ear. Once the ear is dry, one can expect the hearing improvement, and patient with normal hearing, one should always warn them that hearing may come down after the surgery. And then the follow-up. Again, the follow-up is very important. And along with that, the chances of complication also need to be told. And if it is can avoid down, then the regular follow-up every 6 months to clean the cavity. So that's also important. So approaches. So when we approach, once we decide that patient that, okay, he needs surgery. So Dr. Sanjeev Kathuria, so what is, how you go for the patient surgery? What approach you take, and do you always explain them regarding different availability of the approaches and what can be done? Hello. Hello. Dr. Kathuria?
He has to unmute.
Okay, because audio is not available.
He has to unmute himself. Just ask him to unmute.
Dr. Kathuria, I think your